right, David, 3, 2, 1, let's go.
Welcome everybody to the Free2Care virtual conference. Free2Care is a 501c4 organization. We do not, we're not tax exempt or provide tax deductible donations, principally because we want to be involved in legislation and advocacy. And we've given ourselves the freedom to do that. We operate on a very simple mission. Healthcare is about the relationship between doctor and patient. And we seek to remove any third party that doesn't add value to that relationship. So everything that we do is stemming from that singular mission. This organization celebrates its 1-year anniversary this month, which is really quite remarkable when you consider what we've done in that year. I think it's also fitting for us to celebrate those things that we have done. Please allow me to just mention a few of them. It's certainly not an exhaustive list. We had our first conference on April 1st in Washington, D.C., where we had Secretary Ben Carson address nearly 100 physicians in the Library of Congress. We also released our Reducing Cost and Waste from American Healthcare white paper, and it's been distributed widely ever since. The paper outlines 5 platform issues of our organization, and we have exercised a great deal of discipline in sticking with those issues because of that paper, we have been able to grow our membership amongst conservatives, liberals, and across the spectrum because they believe in that mission that I expressed earlier. Our membership, speaking of that, in only 1 year, we have grown to 21 member organizations, and we are we're an organization coalition. We don't take individuals because we do not intend on competing with our member organizations. If there are individuals, we very happily point them in direction of the various groups, depending on their interests or inclinations. So we have 21 member organizations representing nearly 2.3 million individuals nationally, and that includes 37,000 physicians. We have supported bills, we oppose bills, and you can find out more about that on our website, which is free2care.org, and it's free, the number 2, care.org. Our successes are the successes of our member organizations. And some of those that I want to highlight as part of this list is what Physicians for Reform has done with the Job Creators Network in establishing a framework of a replacement of our current healthcare system. Physicians for Patients put out a petition that they've received nearly 25,000 signatures, and they got the attention of the White House that resulted in a meeting with senior staff. And multiple op-eds have come out after that. And in fact, members have been writing prolifically and have appeared in publications such as the Wall Street Journal, The Hill, National Review, and a variety of others. As a group, we've met with the staff of the Senate Health Committee to give them our input. And actually, they requested our input based on some letters that were sent that way. We've worked tirelessly to kill bills that impede great models such as DPC. Everyone came together to support direct DPC action to make their voice heard on House Bill 3708. And again, so many other things that we could discuss. I don't want to take up more of this time, but I'm happy to share those with you. But ultimately, that's what Free2Care is about. It's making the voice of the patient and the physician heard. And I want to thank everyone that is here for the contribution they make in making this coalition not only a reality, but a success. With that being said, I'd really like to extend a great deal of thanks to Citizen Health. They have worked tirelessly to put this together, and producing this conference, and what they have done or what they do is they're a technology cooperative that is building a marketplace to empower physicians and patients, and that's why they work so well within our mission. And I'd also like to remind everyone today, one of the accomplishments that I didn't mention that is very important because we're going to honor them today is the work that has been done by Practicing Physicians of America. They and Dr. West have been so dedicated to this litigation against MOC, which is, again, impeding the doctor-patient relationship. And we are giving a percentage of the proceeds from the donations we're receiving for this conference to their effort. And I hope that you'll contribute to that. And with that being said, I'll defer now to Brennan and have him talk about the run of show.
All right, thank you, David, and hello, everyone. I want to give a kind of some ground rules here and what to expect for today and tomorrow. So today is the first day of a 2-day conference. We have 4 hours today and 4 hours tomorrow. So 4 panels each day. And we're using Zoom for everything. So please take advantage of the chat options on Zoom, questions and answers. And we do have some polling options if the moderators and panelists want to poll during the session, we can do that. So all of this it is being live streamed on YouTube right now and will be broken into each panel with its own particular video at a later date. But right now it is live stream. It will be on the internet forever. So just to let you know that the chat transcript will also be posted as an article along with the video. So all of this will be documented, and we're going to be sharing it around our social media channels to really generate a lot of activity and support for these organizations. So with that being said, our first panel is Navigating Hospital Politics, and it is moderated by Dr. Kat Lindley. So Dr. Kat, I will turn it over to you and go from there.
Thank you and good morning, everyone. Kat Lindley. I'm a direct primary care physician in Texas, and it's my honor to be on this first panel today. And we're going to talk about navigating the hospital politics, and who better than two gentlemen who used to be hospital executives. We have Mr. David Balak, who is the Health Policy Director for Texas Public Policy Foundation, and Mr. John Chamberlain, who is the president of Citizen Health, I believe. Between two of them, I believe there's some 40-some year experience in hospital work, and we'll hear from them and have them talk. First, I would like you guys to introduce yourself to the audience, and then we'll start talking about some hospital politics.
John.
Hi, good morning, everyone. My name is John Chamberlain. I'm currently serving as chairman of Citizen Health. I have over 40 years of healthcare experience, predominantly in hospital executive roles and physician practice management. And of late have become, have always been very impassioned for patients and certainly physicians, because those two form the basis for true healthcare in this country. The physician-patient relationship has been usurped of late, and it needs to be reestablished without third-party interference, hence the name Free2Care. So I look forward to answering questions this morning and talking about how to successfully navigate hospital politics. Thanks, everyone, for being here.
My name is David Balak. I'm the director for health policy with the Texas Public Policy Foundation. I started in the hospital industry. I started when I was 15. I've worked through every department you could probably work in the hospital, and decided to go that route, even though I was pre-med in college. I worked in an ER and ICU, but then worked for some of the big hospital Sisters of Charities, where I got my start, and then in the Memorial Hermann system in Houston, Texas. I didn't play too well with a lot of the corporate types, so I went off on my own and did turnaround work. And I did that for about 7 years, and that's where I found my real joy, because what I found was that if you partner with physicians, hospitals tend to do well, and that's why many of them were run nearly into the brink of bankruptcy, which is just a shame. And John and I saw a lot of the abuses that administration has imposed upon the physicians who they should be partnering with, and we wanted to again impart what we know that could be of service to you all having to deal with those administrative individuals and rules that they use to hamper your care for your patients.
And that said, actually, I used to be employed by a hospital, and it's always difficult to navigate, through those politics and things like that. And from several friends of mine, I hear that when they, start working for a hospital in a clinic or a hospitalist or whatever, they they don't have to supervise anyone. Then all of a sudden it becomes part of their contracts where they have to supervise the nurse practitioners or PAs or things like that. How do you guys, what are your experiences with that? What are the rights that the physician really has when it comes to that if they don't feel comfortable supervising someone?
John, if I can jump in, I think we need to think about it in two separate types of scenarios. What Dr. Lindley just brought up would be an employment contract. And I think what would be best is for us to take one at a time and talk about what are your rights as an employee versus what are your rights as someone with privileges in a hospital. Wouldn't you agree?
I would agree.
And so it always starts with a contract. Whether you have privileges or you're an employee, know your contract, have an attorney read it, understand what your obligations are, and understand the nuance. That goes for the bylaws as well, even if you're not an employee. Understand the rules of the game because they will be used against you at times. So it's always important to have a copy because you'd be surprised. So many physicians that I knew of that did not have a copy of the bylaws and happily give them another version so that they could be prepared. But many wouldn't, a lot of people would not do that because they'll weaponize those bylaws against the physicians.
And I think the distinction is correct, David, that you have to differentiate between being an employee where your options are limited, again, by your contract, as opposed to being a community physician that has privileges. And again, it depends on what privileges, what level of privileges you have. But I think it's important because I guarantee you, those of our brethren that are still employed by hospitals as executives know those bylaws backwards and forwards. They have an army of attorneys that know those bylaws backwards and forwards. And it would be probably one of our number one recommendations that as a participating physician in a hospital, whether employed, which again reduces your options, or more importantly, particularly as we see DPC growing, that are not going to be employed by anybody for that matter, except their patients. If they do indeed utilize a hospital, they need to know what their options are and how they're going to be impacted. So it's very wise to have that not only reviewed by an attorney, but know those bylaws to the best of your ability.
So another question that came up in discussions is actually from some physicians who are specialists or even family medicine physicians who are not part of the hospital group, who are still independent. There is a trend across the country where the hospital kind of starts isolating them and starts putting maybe employed physician hospital, and all of a sudden all of the referrals go to that person and not to the physicians who've been in the community for 20, 30 years and things like that. What are some of the strategies that you guys think these physicians could do? Because I know of several cardiology groups and even a primary care physicians who have had to leave the community because there was no more referrals sent to them, so they couldn't survive.
I think it all comes down to primary care, and the hospitals have that figured out, and that's how they try to manipulate and control really all physicians, but especially the specialists. It's important for your primary care physicians to understand. It's shocking to me how few of them really do the power that they have. Nothing happens without that referral. I learned very early on that nothing happens in a hospital except for at the tip of a doctor's pen. And so if you can support your primary care physician, you can encourage your direct primary care doctors. If you can control your referrals, you have some influence over the hospital. They treat you in a completely different manner. But what I've also seen is even physicians that have a huge referral source, if they don't demonstrate their knowledge of their value, that they will still be bullied in a sense by hospital administration. I think John has probably seen a good bit of that as well.
Yeah, I think too, it's not just primary care physicians and specialists. I had a fairly recent event here. There was a freestanding imaging facility, probably had the best equipment from New Orleans to Tampa. And essentially the hospital-owned physicians at the instruction of the hospital stopped referring to this freestanding center and essentially ran that whole center out of town. And that's a shame because it was not only a very accessible facility, same day service, low cost cash offerings. It basically, they eliminated the competition. And I think, again, David's exactly right. The most expensive piece of equipment in the hospital is not that 3 Tesla MRI, it's a physician's pen. And that's a good thing because they do control. There's not a hospital administrator in the country that can admit patients to the hospital. The only ones that can do that are physicians. And again, primary care docs, those independent specialists need to understand what their value is. And those that do certainly should be able to pronounce that more. And don't be afraid to go to the hospital execs and say, look, I put a lot of patients in this hospital. Now, obviously, it's a lot easier if there are other facilities where they can move their patients to. But in those situations where there are not, it is tough. But I think, again, you go back and look at primary care, and one of the real goals of primary care, and especially DPC, is to keep patients out of the hospital to begin with. So that's another arrow in the quiver, if you will, that primary care docs have. And again, if you have the opportunity to refer to specialists outside of the hospital that are not employed by the hospital or not affiliated, that's what you need to do. If you can get specialty care via other means besides hospital-related specialists, then that's what the primary care docs should do. It's a difficult situation, and the bottom line is that even today, hospital and physician interests are not aligned. Incentives are not aligned. Now, there are a lot of PR, if you will, on the hospital side about, our physicians, we all think alike. Not necessarily so. If a patient's not in the hospital or not receiving hospital-related services, that is not an aligned incentive. So again, I think primary care especially, as David said, is what it comes down to. Do everything that a primary care doc can do, either in office or with specialty care outside of the hospital for a whole host of reasons. The least of which is not, if you send a patient to a hospital-related facility, they're going to get charged an additional fee, known as a facility fee, that they would not see in an independent service provider.
So as a primary care doctor, I agree with you guys, but I actually found that the hospital does the opposite, right? They hire the nurse practitioners or mid-level physicians, and because they want those referrals to stay in the hospital, and they don't necessarily want a great primary care doctor who can do a lot on their own, because the hospital needs revenue with those labs and CT scan and MRI. So it's kind of interesting to hear you guys talk about that, because you talk about it from the patient and physician perspective. You're not talking anymore as a hospital executives, which is kind of nice. I know you both, so I know where your hearts are, and it's kind of nice to see that. But we all see that other side where they want to keep everything in-house to generate revenue.
You're absolutely correct, Kat. That is still today. That's where the money's made. Whether they're admitted as an inpatient or admitted to outpatient services, that's where the money's made. And David and I both, I think I can speak for David, we saw the error in that several years ago. And what we saw was a decline in the quality of patient care and actually a focus. And I think, honestly, to be fair to myself, David, and other hospital execs, at one point in probably all of our careers, we had this more altruistic approach to care, that you took care of the patient the best you could as a hospital. You took care of your physicians so they could take care of the patient. Then everything else worked its way out. Well, unfortunately, as legislation was enabled. I could go on a whole rant about it, but I won't. The focus became money. The money became what drove not a healthcare system, but a sick care system. So in other words, if patients are not being treated for serious issues which require lots of ancillary services, labs, imaging, et cetera, then we don't need them. They're not making us any money. So good luck with that. Insurance companies certainly enter into this whole thing in that the more money the hospital charges, the more money insurance companies make because of the medical loss ratio rule that's in play right now. So I think the incentives are still very much misaligned. David and I both, and I know David well, we both focused on patient care and our physicians our whole careers, but it became more and more difficult to do so in that hospital environment. And we both chose to change our pathway. And
I love what I do now, but I miss the hospital. I'm one of those strange.
I miss buying all the really neat toys. But you know, the fact is they're toys to a point, but that's one reason hospitals have remained successful is they are the deep pockets that can afford equipment that physicians, as we drive more and more to a sick care approach to providing care, they're the only ones that can really afford the fancy equipment.
And you know, hospitals aren't necessarily, I'm not going to say, we're not going to this isn't an effort to demonize hospitals. Hospitals have a great value. John was talking about alignment. The incentives are not aligned. And so you as physicians have to demonstrate your value and demonstrate your power so that you can take the best care of your patients, because that's ultimately what's important. But so let's talk about some certain situations that you've seen, John, and perhaps some from my history. I'll just, here's another piece of advice that I think would be important. If you're called into credentials committee, there's some kind of discipline that's looming, and it starts to progress, and they say, well, we're just going to come talk. Don't worry, it's okay. Which they'll always try to make things a little bit more relaxed than they really are. I would always recommend that you bring an attorney with you. Check your bylaws to make sure that that is something that is not prohibited, because if it's not prohibited, then it's allowable as far as I'm concerned anyway. If they refuse to have that meeting because you have an attorney there and it's not prohibited by the bylaws, you've done nothing wrong. But I was going to say this at the end, but I think John, and I don't want to speak for you, but knowing you, I think you'll be okay with this. But if anybody does run into these kinds of problems, we'll be happy to provide some guidance and recommend attorneys that might be of help that have this kind of experience.
Absolutely. I think another scenario that I heard a lot about, particularly having worked in some academic medical centers, also it still applies in even community hospitals, is the new version of what's called town gown. You had community docs and you had academic docs. But I'd like to take it really to the community level, where you've got, let's say, independent physicians that have, let's say, minimal staff privileges, but because they may admit, 3 or 4 patients a year traditionally, and they get basically courtesy privileges that allows them to admit, let's say, less than 12 patients a year. The problems that raise their heads is really in scheduling, whether it be surgeries, whether it be outpatient procedures. And there tends to be a scheduling difficulty for those independent docs as opposed to the owned or employed. And I don't think a lot of docs like to say they're owned, but if they're employed, they're owned, in my opinion, because their life is not their own. They have no really decision-making ability. But what I'm trying to get to is the dichotomy that exists between employed physicians and independent community-based physicians that have difficulty in scheduling patients. And a lot of that is due to the fact that they're going to take their own first. And it's wrong, but it happens. And I think that's something, again, that the physician that is being discriminated against, if you will, needs to take it up with hospital administration. If hospital administration is not receptive, then take it up with hospital board, because patients are not getting cared for in a timely fashion, and that should not be allowed to happen. And somebody needs to know about it. And again, as David said, if need be, bring an attorney.
I actually have a couple of questions here from Dr. Thompson that are related to what we talked about. So for David, can you give an example of how to demonstrate how physicians can demonstrate their value and power to the administrators? I think you guys touched a little bit about it on it with the fact that, with the primary care and all that, but what about all the physicians just in general?
That's a great question. Referrals, admissions, looking to see what you bring, getting to know as much about what that patient represents to the hospital as possible. Because if you're, a general surgeon and every patient represents $10,000 and you're bringing 100 patients a month, you know what you're worth to the hospital. So it's important for you to get to the metrics. Some hospitals will do it for you. Some have, they started doing that, but then they got away from it because providing that information was more detrimental to them in the way for them to control their docs. So everything is more secretive, as we see in healthcare generally today. But that's what I would do. Create a dashboard for yourself, or have your staff do it. But, how many people are you referring to the hospital? How many patients are you referring to a specialist that end up in a surgical procedure if you're a primary care doctor? Know where your patients are going and know what they represent financially to the hospital, because that's the only language that they speak. I'm not making any friends when I say this, but today the hospital administrator is really no different than a glorified hotel manager. They're not partnering with physicians. There's very little entrepreneurship. They're following policy and building buildings and buying equipment. And there's nothing difficult about that. I'll let you address the question if you have anything to add.
No, I think you're exactly right. And I think there's the mindset of a hospital administrator today, certainly even before I left the field, you tend to look at your top 10 or top 15 admitters, make sure that they're ginning like crazy. Sometimes that second tier gets overlooked because they're not the big admitters. And so I think what David said, I would agree with. Stand up for yourself, do that dashboard. There's all sorts of data out there right now that say that let's say, for instance, and don't hold me to the number, but the average primary care physician in this country is responsible for well over $1 million. I think the one for the average PCP is at least $1.2 million worth of revenue to the hospital. So again, you can break that down, but look at your own dashboard. And I think that's important. You need your voice to be heard. We are trying through certainly Free2Care to have a collective voice being heard, not only by hospitals, but also by the government, insurance companies, et cetera. So I think it's important to stand up for yourself. Again, David, your suggestion of having your staff pull, let's say in the last 6 months, how many admissions you had, how many surgeries you did, how many referrals you did for specialty care, how many referrals you did for ancillary services is important. And that's probably the best way. Hit them in the wallet. Let them know what you're bringing to their hospital and that you need to be recognized for it and you need to be appreciated for it. Again, it makes it a lot easier if you have, another facility in town. You just say, see you later. They'd be happy to take your business, provided certainly the quality and other things, ease of getting patients in is equal or better at the other facility. But you've got to basically stand up for yourself and say, this is what I'm doing for your hospital, and I need these things to happen to make taking care of my patients better, and I'd appreciate your assistance.
Kat, I wanted to address something from earlier, another tool to help physicians protect themselves from administration, because they'll set doctor against doctor, and there will be a lot that goes on, and there'll be phone calls. If things start to spiral, I would always check with your state. Texas is what we call a single party state. As long as one person is is aware that the call is being recorded. It's legal and admissible in court. So you want to check to see if your state is a single party state so that you can, you know, record conversations in the case that you want to remember or take notes on that later. But anytime there's a verbal interaction, a conversation, a meeting, a phone call, it's always best to summarize that meeting and send an email with the understanding of the contents in that email to that person you spoke with. You're creating a data trail. Just like in your clinical practice, if it doesn't get written down, it doesn't happen, right? Same thing in these situations. Document, document, document. The more documentation you have, the better that you'll be able to protect yourself.
I think another way that hospital administrators would like physicians to move these issues to their attention is through the medical staff organization, whether it be through committee, whether it be through the CMO if you have a chief medical officer. Unfortunately, in some of those situations, CMOs are in the position they're in because of their, how should I say, relationship with the hospital CEO and the board, and it may not be there in the best interest of the medical staff members, individual medical staff members. But I think that's probably, at least it was when I was still actively involved, that was the preferred initial approach, was through either chief of staff or CMO or department chief. I mean, it's this layer upon layer, which is one reason they do it. It's called a stall tactic. But I think that's certainly another option. But if it was me, knowing what I know today, I would go directly to the CEO. And, you know, if they throw up a buffer, fight it. Say, I really need to speak to you. I don't want to speak to so-and-so. I know so-and-so, but I haven't had success in getting things done or being listened to. So again, I think that's what's going to happen to a lot of physician issues. They're going to be told to go up through the medical staff organization.
Buck stops with the CEO. Patient safety is always my responsibility. If you don't have a safe hospital, you can't have a profitable one.
And I do appreciate your advice, guys, because, you know, even for myself, some things that I went through, I've never been my own best advocate. And having these conversations where you kind of stick up for yourself and try to explain, you know, and even when you're negotiating contracts, sometimes you just feel, oh, I'm so thankful they gave me something, you know. So having you guys give this advice from your perspective, it's really valuable to me. And I know it's probably going to be valuable to a lot of physicians to understand that we do have a voice. I think we've been told for so long that we don't, that it's sometimes too hard for us to stand up for ourselves. Which I did have a question either one of you can answer, but let's say no one listens, CEO doesn't listen and all that. Who do you go next to?
Before I answer that question, I want to say something. And if I may, Kat, I want to, I hear what you just said from many, many people, and I want you all to change the way that you think. You're not sticking up for yourself. Stop thinking that way, because people tend to be, especially in altruistic careers, they don't want to negotiate for themselves. They're not very good negotiators. They don't want to stick up for themselves. They just kind of take it and go on and you know, do what they were trained to do. Stop that. Don't do that anymore. Don't stick up for yourself. Stick up for the patient. You are there for the patient. And the fact that they're impeding your ability to care for the patients, they're harming patients. That's the way I go. And I guess that's why I have the intensity of fight that I do, is because I see everything that I do for the sake of the patient. And it's not about David, it's not about Kat, it's not about John, it's not about anybody on this call. It's not about anybody that's viewing this video. It's about the patients. And are we going to defend the patients of this nation and give them the best options possible? So go in there and fight for them, not for yourself.
I concur 100%. And guess what? We're all patients. At some point, I've been a patient several times, and you know, my knowledge of hospital world and how things should work as a patient benefits me greatly, has benefited me greatly. I know what to look for, who to look at, who's doing what. And I think that's important, but I agree with David 100%. If we keep that in mind, and I said that earlier, if we keep the patient number one as the central focus, and hospitals need to look at physicians as partners in taking care of patients, not as some means to an end, which unfortunately a lot of hospitals look at physicians as a revenue source. And okay, I understand that's business, but again, I go back to something I learned a long time ago: focus on the patient, take good care of the patient, and as long as you have appropriate protections in place from a financial standpoint, insurance, et cetera, everything is going to work out. But a lot of hospitals, certainly due to all the focus on revenue, I mean, we're a $3.67 trillion industry. There's a lot of money out there. And we need to get back to that. We need to get back to focusing on the patient. I'd like to go back to something that you said earlier, Kat, about, you gave a good example of, as an employed physician, there was no mention in your contract of being responsible for supervising mid-levels. Or if there was, you didn't have your attorney catch it. But the point being, all of a sudden those things change. And the sad part about that is hospitals are hiring mid-levels, in my opinion, more and more because they're less expensive, they're a little easier to control, and they still can perform a lot of the things that physicians do at a higher cost. But to put physicians at liability, because in actuality, if you're supervising a mid-level, you're ultimately liable. And believe me, hospitals have attorneys for one reason. Well, a lot of reasons, but in this particular situation, they're confident that the first line of defense, if something untoward happens, is you as a supervising physician. And I think that's certainly an issue that needs to be remembered, that we've got to take care of our docs, we've got to take care of certainly the patient, but that's not the way to do it. And I think that anytime an administrator wants to, put that onus on you, then your contract needs to reflect it. You need to have an opportunity to respond, get your attorney involved, and make sure that you're not opening yourself up for more liability than you already have.
If you are supervising mid-levels, we were talking about a dashboard earlier. Include that dashboard as part of yours as well, because
Right.
Again, under your supervision, under your license.
That's correct.
And I agree with both of you. I know we've spoken several times. I feel that if we could go back to that time when physician and patient relationship was the most important one, that all things would align, and working with a hospital as a partner, it would be amazing. But in lots of circumstances, now a lot of physicians is not that way anymore. They do see us as just part of the workforce, but not as partners anymore. And I know a lot of physicians are getting frustrated and kind of pushing away from it. And in my case, for me, direct primary care is great because I can shop around for my patients and find what's best for them. I'm not dependent on that hospital, but a lot of physicians are, and it's a difficult environment now. Healthcare is not what it used to be anymore. It's like you guys said, it's an industry. It's probably one of our biggest industries in the United States, and everyone wants a piece of it. And I know hospitals have a huge lobby in DC, and every time we're trying to promote something for betterment of patients and physicians, there's always, something you have to fight from them as well.
Well, it's been known for a while, and I think it's certainly not any truer in the past than it is today. It's been known as the medical industrial complex. And that came from actually an Eisenhower era description of the military industrial complex. And we've kind of changed places now from, although the military is certainly well-funded, healthcare is way more well-funded, as I said, to the tune of about close to $4 trillion. And as you said, Kat, you're absolutely right. Everybody wants a piece of it, and more people want a piece of it because they see the revenue. And I think one other thing you said, which this is very discouraging, that, and David, correct me if I'm wrong, or anybody actually listening, but I think that we've now eclipsed the 50% threshold of employed physicians. By the
Yes.
time and it's not, and I think a lot of times people don't understand, it's not just hospitals that employ docs. Look at United Healthcare through their Optum division. They employ 100,000 docs. Humana employs 33,000. I mean, it's a frightening statistic. And so let's say 51% of the 900,000 docs in the country are employed. That means that many doctors really have no individual latitude in decisions that they make. They're no longer free to make those decisions.
Well, and they're hamstrung because hospitals automatically make more money because of the facility fees,
That's
which
right.
is why we're fighting for site neutrality. That's one thing. The other thing is this silly moratorium on physician-owned hospitals. When you talked about having your incentives aligned, that was when it was more aligned, is when the physicians were the owners of the hospital because they were looking out for patient safety and they were able to augment their income. And then you look at the other thing, yet another thing that we're looking at really bringing more attention to is these tax exempt hospitals. I don't call them nonprofit anymore, but they're benefiting. They're benefiting from this tax exempt status, and they're saying that they give charity care, but they're basing all of this supposed or alleged charity care on the discount from their charge master, which is an astronomical, fictitious number. So they're playing a shell game and manipulating the system for their own benefit, and they're not helping patients. And it's just, again, there's a reason why I'm not in that business anymore.
Same reason for me. And I agree, this uncompensated care, this discount from bill charges, that is a shell game that is unbelievable because there's no control over charge masters. And this recent effort by CMS to get charge master pricing out, well, that's a jumbled mess, and there was no guidelines as to what format it had to be put in, so to speak. And so you get a poor patient that's going to look at a hospital charge for, let's say, just a laparoscopic cystectomy. And I'll give you a perfect example from personal experience. I had one of those about 2 years ago, and the bill charges that I got from the hospital that I went to were over $76,000 for a lap chole.
Well, you had a discount.
Yeah, I had a discount. The funny part is, being a Medicare recipient, you know what the hospital got paid? 12 grand. So they billed 76, they got paid 12. The 64,000 went to, guess where? Uncompensated care or contractual allowances, so to speak. Now, for somebody without insurance, the hospital, and I asked the question because I've been in the business, I said, what would you do for an uninsured patient if in the first place you allowed them to have the procedure there? They said, well, we would give them a 50% discount. I said, oh, that's generous. So you're only going to charge them $38,000 for a lap chole? That's unacceptable. And that's really a very good example of where we are today. It's not laughable.
That's just the facility fee. It doesn't include the physician and anesthesia.
That's right. That's
whatever else may be the case, whatever they order.
It was well over 80,000 by the time that came to be.
So you guys are going to, well, I think you're going to be proud of me. So you both know I do a lot of advocacy and all that, and I'm currently president of Texas ACFP, which is the Osteopathic Family Physicians. And I was asked, where do you see family medicine going and things like that. And my answer to when people ask me, how do you think we're going to healthcare and all that, I say physicians, we have to wake up. We have to wake up and realize that we don't need to be employed. There are other venues for us. We need to I call it unplug from the matrix. I'm a huge Keanu Reeves fan. So we have been it's almost like that movie Matrix, you've been kind of preconditioned, this is what you're going to do, and you finished residency and you have so much debt, and you're like, okay, I'm going to go get this job because I need to start paying off my debt. We don't realize that, that there are banks that are going to give us loans because we are good investment. And, you know, I really think that one of these days, I'm hoping that we can have this physician revolution where we realize that medicine, healthcare doesn't function without us. So we need to take back our voice for our patients and start saying our patients need us and you need us. So we can all do this together, or we don't have to. And I'm a firm believer that physicians start going back to independent practice of medicine, the whole healthcare system will be better because we are the true advocates for our patients, not the hospitals. So what are your thoughts about that?
Sorry.
My Siri is going to answer.
Well, I couldn't agree more. I think, again, that's certainly part of the reason that Free2Care exists, is to help get this physician voice collectively heard. And you can't do it you by yourself, DPC Action by itself, any of the direct primary care associations or groups that are out there currently. They're all great, but it's still a very almost inaudible voice. And so the need is there for an organization like Free2Care. And there are a couple of others that are looking at the same concepts that we're currently via Citizen Health talking to about why are we all going in different directions, in different groups, when we should all be headed in the same direction. And again, I think the bottom line, I certainly know this for Free2Care, is physician voice and patient voice. And those of us on the periphery, if you will, from an administrative standpoint, David and myself, David's a little more involved, well, a lot more involved politically than I am. But I think, again, that's where the sausage is made, if you will. Nothing happens without appropriate legislation, but without the appropriate voice being heard, that legislation, and it's a perfect example is HR 3708. That's currently it's already rolled out of Ways and Means. It's got some bad stuff in there, and it does not need to go in be approved in its present format. Section 5 of the recent executive order on saving Medicare. Again, the rest of the executive order is pretty good, but Section 5 is horrible. And if we don't have a loud enough voice, it isn't going to matter. It's going to be legislated through, and we're going to all suffer the consequences.
Well, and as I said in my opening statement, couldn't be prouder of the activity and the actions and the groups coming together, because we put out a call on an issue, and boy, these member organizations of this coalition know how to rally. But Kat and John, we've got some questions that we have not addressed, and we're coming towards the end of our time. I just wanted to make sure that we address some of them. The ones from an anonymous attendee. You don't have no anonymous attendees. Come on, guys. Let's see. It says, with impeachment slowing down the legislative process in Congress for the next year, what do you expect Congress will actually get done over the next year? Absolutely nothing.
As long as they don't pass 3708, I'm good.
Well, you're not going to get a lot. There's not much that's going to get done in a divided Congress. When whatever good things the president can get done through an EO will be demonized in public. There was the relaxing of the waivers under Obamacare for the states to create more innovative models, and there was a vote in the Senate here recently, and that was it was voted down along party lines. But make no mistake, it wasn't about healthcare. It was for political posturing, which is what you'll see for the next year or so. The only way something will get done is if you have a majority party in every branch or in every chamber. Let's see, another question is, admitting privileges and physician contracts are hardly contracts, they're more mandates. Do you have recommendations for physicians for how to truly become negotiators for themselves? John, you had a quick.
Yeah, I think, again, certainly, reach out to an attorney. you should have one at least, that you're involved with in establishing your practice or for other reasons. Seek their advice, but there are lots of folks like David and myself that would be happy to provide, some assistance in that. Find somebody that you trust, a good business person, and tell them the situation and say, look, I've, whether it could even be family. You may have, a family member that's got an independent business that could provide some assistance in that. But there are ways to get that information. And again, it's some of the things that we've talked about today. Take it upon yourself. Get your arrows in your quiver and go. I know that, as Kat said, it's not necessarily something that physicians have been known to be famous for, some more so than others. But if you're not going to stand up for yourself and basically put together the information you need to negotiate, then you need to either find somebody that will help you do that. But to just sit by and idly, suffer the misfortune that you might encounter isn't an acceptable answer. But I think, again, reach out to somebody that that's successful in business, that maybe has, I'm not going to say go take a negotiating skills course, a Charlie Karras course or what have you, but you have to distance yourself somewhat from the day to day if that situation, occurs, and find yourself some assistance to do that. It is possible to do.
Let me just jump to a question from Dr. Sussman. How do we fix site neutrality, surprise billing when judges keep shooting these interventions down? Pressure from patients would help our cause. The powers aren't going to listen to physicians. I agree and disagree. I do agree the patients are going to help, but the physicians are going to have their voice will be listened, but it's been difficult when it's been fragmented in the past, which is why there's this the benefit to having this coalition coming together, having our voices magnified, patients and doctors standing shoulder to shoulder and saying, no, that's not right. And doing all that we can and making phone calls and writing letters and sending emails and doing what we do best.
And David, if I can also answer that from my standpoint, I found that we as physicians have done a poor job in the past. The coalition is great, and I 100% agree with everything you said. But you also, and this is something that we as DPC Action do all the time, you have to go to DC. You have to meet with them face to face, or go where they live. If they live in the town close to you or a few hours away, you have to meet with the staffers. They have to know you by name. My senator staff knows me by name now. And that's important because otherwise they don't hear from us. And when they don't hear from us, they think that we agree. So although I agree with David, the coalition is the way to go. Once in a while, you have to show your presence. And David does it for us all the time, but physicians have to stand up and invest their time and money into it as well.
John, I've got a question here for you from a physician. And the physician says, when I document hospital deficiencies, I've been called in and told to stop. How would you advise that person?
I think if you're not getting heard, and it depends on who's calling you in. If it's administration, then you need to go to your medical staff, your CMO or your chief of staff, and say, you're trying to bring this to the attention, or go to the quality committee. Whatever the case may be, if you still have no success, find yourself a board member, because they have the ultimate fiduciary responsibility, certainly in these tax-exempt facilities. Now, that's not the case for the for-profit hospitals. Boards in those situations are purely advisory for the most part. But find yourself a board member that's, again, they're ultimately fiduciarily responsible. They need to know about it. If you're not having success, find a board member that's willing to listen and say, I'm not having any success. And these are definitely issues that are going to impact and have impacted patient care in my experience, and they need to be corrected. And I'm getting stonewalled.
I would add to that by saying this: if you're directly impacted in those deficiencies, if it's your patient and is a potential harm to your patient, then don't stop, because
Right.
it not only impacts your patient, but it impacts you. And continue to fight that. And I would couple it with, remember your value. Uh, you're benefiting them. They're not doing you any favors. You keep them employed. And oftentimes that's the tact or the approach that we take with our representatives and our lawmakers. They work for us.
Right.
So we should not, oftentimes people say we have a royal class in this country and it's our members of Congress. That's not the way that you walk into that meeting. And don't go in braggadocious or with ego. You want to go in and have them work on your behalf. Many of them don't understand healthcare, and they want to hear from you. You're going to be one of the few people that aren't getting paid to be there. You're there because you care about your patients, you care about the community, and you're there spending your own money and foregoing money you could have made in your clinic so that you can tell them what you believe is right.
I see a question that was asked about medical loss ratio, and in a short description, insurance companies under the ACA legislation, which is now expanded, of course, to everybody else, have a requirement that they pay a minimum of 85%, and typically it's 80%. 80% of the premium dollar has to be spent on medical care. The other 20% or 15% in extenuating circumstances is considered their, for lack of a better term, profit. So the reason that insurance companies have no incentive to lower hospital charges is the more money they get charged, yes, they have to pay 80% of that, as towards medical care, but that 20% all of a sudden becomes a bigger number. So if they're getting $100,000 instead of $80,000 for a procedure, they have to pay the concomitant 80% of that off to charges. They have to actually reinvest that into care. But the more money the hospital charges, their percentage gets bigger, in short. That's how that works.
They're very good about getting to that 80%.
Oh yeah.
They'll create committees, internal committees, and create a budget for that committee to allocate percentages of that money to get up to that 80%. So they're not leaving anything on the table.
Right.
I think we've come to the end of our time, guys.
We have.
All right. Yeah, we are reaching the end. I've copied all these questions, so we might need to go back and just kind of create an FAQ maybe for after the conference. Get some answers on there. Well, everyone, I appreciate this panel. I appreciate the time. And if there are no more last minute points to make, we can transfer over to the next group of panelists.
Go ahead. Look forward to the rest of the conference.
Thanks everyone for attending.
Y'all. All right, I am now adding the new panelist. All right, hello, Marnie. Let's see here. You are now live, Marnie. Hey. I think you're muted, so your microphone is muted.
Can you hear me?
Oh yeah, we can hear you now. All right, how are you doing today?
I'm doing well. So happy to be here. Thanks for having me.
Thanks for coming. All right, well, let's see. Dr. Chris could not make it today. She had a conflict of times. So Dr. Judy, let's add you on here.
I'm here. Just a second while I start my video. My start video button is not responding. I'm continuing to try.
Let's see.
It worked a few minutes ago.
Here, let's, can you try that?
There we go. You let me on. Thank you.
All right. Well, I will turn it over to you all and I will step out.
All right.
So good morning, Marnie. So nice to meet you, if only virtually. I look forward until the time when we really do get to meet each other.
Yes, definitely. So we are here today to discuss physician health and well-being, which is fortunately becoming more of a topic in the mainstream. It's something that all the hospitals and people who are not physicians are becoming aware of. And there are so many facets to what affects physicians' health and well-being, and also a lot of downstream effects of what happens when our health and well-being is affected. So, Dr. Thompson, what would you say are the things that are in the forefront of your mind about the biggest contributors to the problems that we're seeing as far as our well-being?
Well, if I can just start from a side trail.
Of course.
I have my screen up, you see it reflecting in my face. On October 23rd, JAMA produced an article improving the system to support clinician well-being and provide better patient care. Their emphasis being on the system, and they used a human relations and systems design engineer to generate the information that was used in this publication. And she really clearly differentiates between system elements that contribute to what they call clinician burnout. And then there are the human elements. And this particular article only focused on the system elements. It was very interesting in that she came to the conclusion that her investigations did not really produce any actionable items. And I'm not really sure what to do with that piece of information, because I don't think anybody would take issue with the idea that there is room for improvement in the system, in the workplace, for healthcare professionals of all varieties. She then diverted, and this is interesting, to established guidelines for workplace well-being that are targeted especially at healthcare corporations. Those guidelines didn't become visible to us, but it's interesting to me that while this medical industrial complex that John made reference to earlier has been being developed, I really wonder if any type of established system guidelines were ever made reference to. So I've kind of made this long entry into the conversation because of the time that I'm spending with this article and the emphasis on data to substantiate the claim that there's really a problem. So let's, from my point of view, the house is burning, although we cannot find data to validate our claims that I'll say the house is burning, and I don't mean to be hyperbolic in any way, although there is some, there's documented evidence of widespread prevalence of physician burnout, physicians quitting, early retirement, physician suicide rates are as high as they've ever been. And what is contributing to these things? It's that whole system that the systems engineer made reference to. It begins in part with the very poor implementation of very poor technological tools, the electronic health record. It's really an obstacle that's interposed between physicians, other healthcare clinicians, nurses, pharmacists, physical therapy, the whole 9 yards. In order to communicate with these people, we have to jump into this big, messy, laborious, frustrating tool to communicate in the end rather poorly with one another, when really what we need is not only patient-physician relationship, but physician-physician relationship and physician-clinician relationship. And Marty, tell me when you want me to stop, because I can keep going and I don't want to occupy our whole time. Go ahead.
Well, no, you make a lot of good points. And I think, of course, in medicine, basically everything we do is evidence-based. We hang our hats on the science. And so it is difficult for us sometimes to explain to people outside of medicine what it is that we're seeing and how to fix it. And I think another huge issue that we're seeing is that we had a question about what percentage of our well-being is affected by the EHR. And what we're seeing is that physician autonomy is significantly compromised, and physicians are being directed to do things by people who do not practice medicine. And so they don't really know what it's like to be in the thick of it with patients. And so what are your thoughts on that? The loss of autonomy and how it affects everyone?
Yeah, I translate it into loss of personal freedom. You're right. These third parties, I'm going to add to electronic health record system something that all of us are very acutely aware of at this time, and that is administrative burden, which I describe as repeated acts of futility. So, you know, we have had robbed from us our ability to use our intellect. At the time that I want to spend listening to a patient, asking a patient questions, doing a physical examination, reviewing laboratory data, reviewing literature to make decisions about how to treat a patient, I waste one very quick, simple example that we can all relate to this morning. I was trying to discharge a patient. Very simple, clean case. Disruption of the electronic health record system. It ate up 30 minutes of my time before I told the IT person, who was doing the very best she could to help me, that I had other things. They just had to find another way to get this done, because I was not going to sit with them. And that happens repeatedly throughout the day. So one of the things that this really wonderful systems engineer made reference to in her article, her JAMA article, and I am preparing a letter to the editor, which is why I'm so deeply into the article right now. She makes reference to systems that have positive outcomes, which we are readily visible, you know, right in front of us in the whole country. There are big, big organizations that get a lot done, that have happy employees. Oh, by the way, most physicians had no intention of becoming employees and have been compelled to become employees. That's a big root of the problem right there, is compulsion. Now, if you choose to be employed and you're happily employed, then that's a whole different paradigm. But for people who've been put out of business, and if you want to pay your mortgage and meet your family's needs, then you're going to have to become a data entry clerk for the man. That is really morally disturbing, big source of trouble for people. The system that has evolved, I do not think it has been designed with any forethought, is a system that has negative outcomes: frustration, anger, helplessness, futility. These emotions lead to negative outcomes for patient and physician. So I think that there is a lot of room for improvement as we begin to focus on the system rather than the clinician as the source of the problem for physician burnout.
Yes, absolutely. And that is, what most of the studies looking at burnout say, is that we need to address it from a systems perspective, which is difficult because there are all these, physician wellness programs and hospitals, and they say, take care of yourself, do yoga, do whatever, do resilience training. But it's not addressing the system. And
It's a band-aid for the problem.
yeah. And I think something that really strikes me is that if you ask almost any physician why they went into medicine, they'll tell you because it is so rewarding to be able to take care of patients and really, connect with people and feel like you're making a difference. And, getting through medical education, getting through residency, getting through all of that isn't for the faint of heart. There's 80-hour weeks, 80 hours plus for at least 5 years consecutively, lost time with family. There are so many unquantifiable sacrifices that can only be, it's only worth it if you are able to do what you set out to do, which is take care of patients. And so I'm interested to hear what you think about, the systems impeding our ability to actually take care of patients the way that they should be taken care of. And so
Yeah.
the solution that results from that inability.
It is. And I think David and John gave us some good initial starting places with how to address that. You made reference to why physicians went into medicine. Very nice physician survey was done by the Physicians Foundation, and it documented by querying multiple thousands. I don't remember how many thousands, but it's a very well respected physician survey from 2018. Why physicians went into medicine? Some went in for the money, and those people have left and should leave. Some went in for prestige, and prestige can be outward or inward. So if you went in for the prestige and that prestige is really important to you, I say march to your own drummer, look into your own heart, congratulate yourself for the good work that you do caring for your patients. You can be very, very proud of yourself and continue to morally survive in a very difficult environment. And then the third reason that physicians went into medicine is because of the personal gratification that they experience by caring for patients. And that can be preserved. You just really have to know who you are, what your values are. I spend a little bit of time every morning myself, doing my best to get off on the right foot and be sure that I meet my own higher needs by helping my patients. And when they turn around and say thank you to me, which they do in more ways than I can count, I feel very fortunate, then I'm really deeply satisfied. Now, by the same token, it's a fight for the money. And I've never been one to fight for the money. It's not natural to me. But my intellectual property, my real property, my building, my computers, my staff are all being stolen from me by people with whom I have very little, if any, ability to negotiate for fair compensation for my intellectual property or the services, procedures I provide. And that's what really sticks in my craw, to put it nicely. I wrote the comment about a contract being a mandate. I have reviewed some contracts, I have negotiated some contracts, and our ability to defend ourselves against these big systems is really very limited. But although, like David and John said, we absolutely must. And if we don't, frankly, it's all over.
Yeah, you bring up a really good point, and that is the continually shrinking reimbursements. And I think something that is pretty significant is the public perception that physician salaries are the reason that our healthcare dollars are, you know, so abundant. And really, we cost 8% of what this country spends on healthcare, 8%. But
It's a good example of a term that I don't like, fake news. Go ahead.
yes, exactly. And one of my favorite infographics is the chart that shows, I don't know, 450% increase in administration and administrative dollars being spent, and the physician increase is like, you know.
I think it was 3,000.
Yes, you're right.
Yeah, it was 3,000% increase. And it was either the number of executives or reimbursement for executives. That I don't remember, but very easy to see where the healthcare dollars are going. A really interesting guy, entrepreneur by the name of, let's see, by the name of David Chase, who used to be COO for Microsoft, if I'm correct, who is now a really strong advocate for patients and physicians in the country. When he was working for Microsoft, he at the top of Microsoft's budget was salaries. The second was benefits. So they said their benefit costs were very high, and they decided to investigate where that money was going. They followed, for ease of conversation, $2 into the healthcare benefits industry. And as soon as those $2 got through the door, one went north to the executives, another went south to what was an unacceptably low quality healthcare product for their employees. So they created their own healthcare plans. All of that to say, yeah, we do not have control over the media. Physician salaries are not the cost drivers. It is, you are correct. People in our society believe that it is, and they're continuing to be told that it is, which is in part why we must continue to do things like what we're doing right now. And that is get out and raise our voices and let the truth be known, as well as share this information with our patients, which I do on a daily basis. Some of them are clueless about what's happening, but very interested.
Absolutely. That is something I've noticed also, is that there are some who know and some who don't, but when they realize, it's shocking and horrifying to them. And I'd like to point out what Mr. Blatt said, 8% before overhead is taken out. So it's even less. But what do you think?
So that 8% represents physicians. I guess that's what, 8% of the national healthcare dollar or GDP goes to physician salaries. And then we have to pay our own staff and our mortgages and all of the equipment needed in our offices. And when all that's done, we get to take something home.
Right, exactly. I wonder, what do you think, and maybe I'm sure that from a surgeon's perspective, this will be really interesting to hear. What do you think about physicians being kind of outmoded or replaced with alternatives?
Are you talking about artificial intelligence or robotic surgery?
Intelligence, different types of professionals, which is great. I mean, a team-based care is, you know, by the data, the most effective. But we're seeing physicians losing their jobs.
So a friend of mine, very aptly, Dr. Venu Julapalli, for any of you all out there who know him, says, evidence informed, but not evidence enslaved. So I think that AI is coming, but I also have reason to believe that it's farther away than we're being told it is. When it comes, my personal intention is to learn to use it and to stand on the shoulders of AI and be a better physician because of AI. my personal experience in the operating room is that I can see a role for robotics, but not independent robotics. Robotics have got to be overseen by human eyes and mind and hands. I believe that this medical industrial revolution is not unlike what happened to farmers in the early 20th century, when people who had family farms and had farms for generations, as some independent physicians have, you know, generations of family members who have been physicians in their practices, who only had a horse and a buggy, could not even fathom what was coming their way, but it came anyway. The future came, and the past does not come back. And I believe that the same is true for the healthcare industry, and that we are somewhat blindsided by what we've been overtaken by, and these bulldozers have already rolled. So people all over the world have survived revolutions in the past, and survivors are people who did what was necessary to adapt. They were honest with themselves about what the circumstances were, which I believe that we all must be. And I'm going to take a step back and go to that change of mind set that David made reference to earlier. And there are some book resources that I'd like to make reference to, Marnie, before we reach the end of this hour. People are saying, you know, what resources, what tools are out there to help me make that intellectual and emotional paradigm shift to stop seeing myself as a frog in boiling water or victimized by my circumstances, and rather empowered to adapt to these changes and learn what I need to know, and then do what I need to do to both survive and thrive in a new and very rapidly changing environment. So now I'm going to circle back as somebody who has been a part of this revolution for the entirety of my career, and have technology being shoved down my throat, and I avoided the keyboard and the screen for 20 years until I realized I was 20 years behind the times. I think we'd better face the music, learn what we need to know, and take action to adapt, survive, and thrive.
Yes. I think that something that was pointed out in the previous panel, which I was really happy to hear, is that physicians together, we have so much power. And as soon as we realize that, we can really change the tides. So, you know, these organizations like Practicing Physicians of America and, you know, this whole Free2Care coalition, it's, you know, they're really making huge strides. And so it's happening. And
I can comment if I may. So I got dragged into physician advocacy by a dear friend of mine who, let me not go down that trail. But anyway, in a way, if he didn't plant the seed for the physician movement, which I know he didn't do, he provided the impetus for the next big wave. And that was in 2014, 2015. We held a week-long conference in Keystone, Colorado. The summit at the summit, it was national grand rounds on the state of medicine in America. We had the AMA attending. We did make a splash. At that time, one of the things that I did to make that happen is I kind of went around the country and knocked on the doors of the existing physician advocacy groups at that time and said, hey, we're having a party, would you come? And the leadership came. We were really disappointed at physician response, but we had about 30 leaders from physician advocacy groups, very, very small groups from all around the country. So that's less than one physician advocacy group per state show up at the meeting, and it was really an historical event. So there's been a lot of water under the bridge since 2015. So here we are now at this virtual Free2Care conference where we can all get together and share our thoughts with each other without having to take time off from our businesses and get on a plane and get a hotel room and blah, blah, blah. So this is a wonderful opportunity. Thank you very much, Citizens Health. My observation is that this physician and citizen advocacy movement, what was a trickle in 214, 215 is a traffic jam now. So please be encouraged. We do feel helpless. It is very difficult. In Washington, a legislator said to me, "Don't you understand that the lobbyists are in our offices every day?" And I said, "Yes, I do. But you know that I, as a physician, I'm speaking to all physicians listening, I took time off from my practice. I bought a ticket, a hotel room, and I'm meeting you face to face to tell you what matters to me. And if you have a moral dilemma with who you're going to listen to, me or a lobbyist, let's hear about it right now." And his response was, that was a good one. So yes, we do need to go to Washington. We do need to know our legislators. We do need to have their phone numbers on speed dial. We do need to get to know their staffers. They need to know who we are, and we need to tell them what matters to us so that once they get to the floor, they can vote on our behalf. If we don't do that, we are victims of our own inaction. Now, you made reference to the possibility of physicians coming together across the country and raising our voices and wielding our pens, which we can do. And I'll tell you, we've been trying really, really hard. Bunch of really good people. There's a whole bunch of really good, very active, valuable physicians advocacy organizations out there. But as the leadership of these organizations have come together, to be very honest with you, we're struggling with some pride of possession, some history, some interests in one subject or another that is have been. I'm going to use my own words here, and not to put words in anybody else's mouth. Are excuses for not coalescing into one unified voice. Where when we show up in Congress, and there are a lot of us in Congress right now, we got a few who have access to the White House. There are many of us who are lobbying at state levels. But unfortunately, when we go, we don't get to take with us the full number of physician advocates that are available because we haven't been able to set our differences aside and create a unified physician voice. That doesn't mean we're going to stop trying, because we won't stop trying. We'll get there one day. One day we will arrive to Washington representing the largest number of physicians in the country, and an unnamed organization will be supplanted, and it will be by us, what Margaret Mead calls a small group of interested citizens that made a difference, and nothing else ever has. Thank you for giving me so much time.
That was very well said. And I think I love what you said too about that we're not going to stop trying. And that's the way that it's going to happen. So let's see. There's a question here. The projected physician shortage over the next decade, potentially 122,000 by 2032. So essentially a supply and demand question. Do you think that's going to happen? Do you think that we're going to see the supply and demand curve come up for us?
Yeah, a couple of things are happening. Number one, because of burnout, which we haven't really talked much about, and I think we ought to try to circle back to that for people who are interested. It is a number one issue of importance. Yes, we're going to see a shortage of physicians because people are quitting, they're retiring early, they're going into other businesses, or physicians are committing suicide. Physician suicide rate is the highest that it's ever been in history, and it is the highest of any profession in the country, and that is a tragedy. The other thing that's happening is that employed physicians, and we're right up on the evanescence of this problem, employed physicians are about to be replaced by employed mid-levels. We saw it in San Antonio recently, where a bunch of anesthesiologists were released from their group and were replaced by mid-levels. So you have unemployed physicians floating around out there. And I don't mean to light the fire, but there are going to be many more before this is all over. So what's going to happen, in a nutshell, people are going to die one way or the other. There are going to be fewer physicians, and those who survive are those who are able to thrive within the system or adapt, survive, and thrive in a new, innovative healthcare system.
Yes, and I'm glad you brought up the physician suicide rate, because that is not something that is well known by the general public. And it's, you know, between 2 and 4 times what it is in the general public. And, you know, of course, there are a lot of theories about why that is, but absolutely, without question, a huge component of the reason, I believe, is whether you want to call it burnout, whether it's, you know, there are a lot of terms being used for this phenomenon that we're seeing. And you're right, there is an exodus from medicine. And it is really scary, because what happens when all the doctors are gone? I don't know.
You know, I think it'll come full circle. I think that citizens, patients, and as John said earlier, we are all patients.
Mhm.
You and I are going to land in a hospital one day, and an employee is going to arrive to the bedside to do a history and physical. And you and I may or may not have something to say about who that employee is or what their level of education may be. And we're going to be impacted at a visceral level. And we're going to say, this is unacceptable. And we're going to begin to innovate and create what it is that we want for ourselves, our families, and our community members. I think part of the pain that we're experiencing right now is the splitting of the American healthcare system into what may be, you know, 2-tier system. And so that when we land in a hospital, or if an individual lands in a hospital, they may begin to have some choice about who it is that arrives to the bedside. And they may say, I have the privilege of choosing who comes to see me. And then we make that choice, in which case we're kind of reverting back to old-fashioned medicine, where that person has a relationship with a physician who they choose, which is really what we're fighting for right now. And if it happens to be that you are not in position to have that privilege, then you may kind of have to eat what you're served and be cared for by the individual who comes to care for you, who is functioning under the mandates of somebody who is not a healthcare professional. I want to circle back to this issue of mental health. It's called a mental health issue, and maybe it is and maybe it isn't. And I say it like that because I have learned recently how important sleep is for our mental health and our overall well-being. A fellow by the name of Matthew Walker has done some groundbreaking science, and he's written an international bestseller, Why We Sleep. If you haven't read it, it's worth the read. And sleep is third in line, following oxygen, water, and sleep. We'll die of sleep deprivation before we'll die of food deprivation. I think that what we're looking at is an epidemic of clinician exhaustion. And when we are mentally and physically exhausted in all of the ways that we are, which was the question that you asked me at the beginning of this presentation, why are we exhausted? But when we are, that's when things start to break down. And I said to you in a conversation that we had earlier this week, you take this group of exhausted individuals. There's an expression that the system engineer used in her JAMA article. She called it presenteeism. There's absenteeism, and then, you know, if you don't show up for some reason. Presenteeism means that physically you're there, but for any one of a number of reasons, you cannot or are not functioning at your optimum capacity. Yeah, there's a lot of presenteeism out there right now because clinicians of all types are emotionally, intellectually, and physically exhausted, not only by the electronic health record system, the system as a whole, the administrative burden, the drive to focus on profit rather than patient care, and the list goes on.
Yes. Couldn't have said it better myself. I want to just bring up one other thing, and that is, I agree with you that it is most likely mostly not something to do with mental illness or whatever it is that you want to call it. This is, you know, something that is happening to people who are, you know, overachievers. They have to be put in extraordinarily difficult situations, and withstanding immense pressure and functioning with exhaustion, like you said. And so then we see a constellation of things happen. But something else that we see that is very concerning is that, you know, when you're exposed to traumatic situations on a regular basis, I'm sure as a surgeon, you understand that, you know, you can't control everything. Sometimes people don't do well, and you have to be affected by that. You know, if you're not affected by that,
You're not
that's
human.
impossible. You're not human. We all are human.
Mhm.
But there is this perception that physicians aren't susceptible to being affected by those things. And I don't know if it's because people need to see physicians as somehow more able to control chance than other people, and or that they should be able to withstand anything and not be affected.
You know,
But
I wonder, do you want to finish talking and I won't interrupt you? I'm
oh,
notorious for it. Go ahead.
I was almost done, I promise. I was just
Go
gonna,
ahead.
you know, then it is such that physicians don't have access to mental health resources because there's licensure concerns and stuff. They're not supposed to be affected, so therefore they don't need care. So
Back to
sorry.
the back to the JAMA article, and the reason I keep connecting us with the JAMA article is because this systems engineer addressed that very issue, and these topics are coming up, and somehow we may be able to begin to cross the schism that there is between independent thinking physicians and a system that, at least for the foreseeable future, isn't going to go away. So what this systems engineer, one of the suggestions that she made was that the stigma and penalties for seeking any type of mental health assistance be removed from the record. Physicians who need psychological or psychiatric or supportive care, or need to take time off to address real life issues, not have that be a part of their record and their licensing, credentialing, malpractice. So protection for our personal privacy as we do the things that we need to do to protect ourselves and take good care of ourselves as human beings. So it's really nice to hear the system at least acknowledge that that is a real human need that we have, and that we ought to be able to meet those needs in private without them being used to penalize us or hold us back from what we need to perform our profession. But I do want to take a moment to say to anybody who's listening and might be struggling with burnout, you must take care of yourself before you can take care of anybody else. And how to do that is a question. You know, I'd love to say, give me a call. I love to talk about it. I also know I don't have another minute in my day, but give me a call. I'd love to talk about it. Let me just say my cell phone and then I'll shut up. 830-608-4367. If you think you're in trouble, please call me. You're not alone, and we will help how we can.
Yes, thank you. Thank you so much for saying that. And I want to echo that. That is obviously a significant interest of mine. My organization, Mainstream Medicine, is part of the Free2Care Coalition. And that is what we focus on, the well-being of people who cannot access care. So we are here, and I think we are at the time for questions. So here we go. Okay. To take burnout more seriously, perhaps it should be reclassified to a higher level in order to show the severity. Perhaps it should be a form of trauma. Earlier this year, the World Health Organization reclassified burnout as an illness.
That's absurd.
It's absurd. But to classify it as a form of trauma, I like that better. I mean, it's a result of trauma. I mean, there are so many different kinds of trauma. The general definition isn't what everyone always thinks of. So
I think it's really important for us to at least consider not seeing ourselves as victims, and rather to see ourselves as individuals in a society that is going through change. And I'm not going to say it's not painful. I feel it. I've experienced it. But I think if we see ourselves as victims, we really get this thought in our heads that somebody else can do for us what we really have to do for ourselves. And that is make that mindset change that David made reference to, and understand that we are both valuable and powerful. David has asked more than once, but David, I can't see your comments or your questions. I'll try to pull them up. What are organizations doing? And I can only see part of it, maybe to help address physician burnout. Marnie, can you speak to that?
Oh, absolutely. So there are, a lot of efforts to improve the system. And we're seeing that a lot. Something that I had not seen is a resource for mental health care that is completely anonymous, off the grid, doesn't use the same sort of information storage systems that everything else does. And so that's why I got into this. But there are so many physicians who are advocating for changes that will help burnout. And I think it would be great to post a list of those organizations because there are so many resources.
Yeah, I agree with you. Are you not starting an organization of your own?
Oh yes, we exist. We're a 501c3 nonprofit.
Tell us the name again, please, and your website.
Sure, it's Mainstream Medicine. That is mainstreammedicine.org. And we're actually starting a clinic third Thursday of every month. And it's pay what you can, so free if you want, or you can make a small donation. And this is for medical trainees, so medical students and residents, and first responders, because they are the populations that they run toward the fire, toward the trauma, and they don't always have the time or resources to get the help. So we want to make that easier, and so that's going to be in New York and Ohio.
Excuse me just a second. I have a book just within my reach, but I have to jump away from my camera, written by a very well-known national physician advocate named Pamela Weibel, and it speaks directly to the issue of the trauma that is experienced by physicians, residents, and medical students. Give me just a second. I'll be right back.
So,
can you see it? Human Rights Violations in Medicine, the A to Z Action Guide by Pamela Weibel. I really have to throw a shout out to her. I think she's probably done more than any one physician in the country to acknowledge, define, and provide us with resources to address this problem. So for me, that's going to be an important starting place, as well as mainstream medicine. And I'm sure I'm overlooking others out there who are addressing the issue. Please forgive me. I wish I had made a list of who you were so that I could read them off, but I'm sure that they can be searched and found pretty easily online.
Yeah, and what Dr. Weibel has done is absolutely bring attention to this massive crisis in our country, and that, you know, awareness is the first step to solving any problem. And I think that is something that we're kind of up against, is that people don't know what's happening. And even within the medical community, people don't necessarily want to even think, wow, I really need help here, because we're all so competitive. It's like, if you admit that you need something, it's like, you know, but really we all need something. And
So, hey, we do. And you're just leading me to something that's so important. And let me write it down so I can stop interrupting you. Go ahead.
please go ahead.
So it's very interesting. And I remember when this happened, it was before your time, Marnie. Physicians used to have a private gathering place where they could come together, let their hair down, be human being, discuss cases, life issues, and more importantly, experience fellowship. It was called the Physicians Lounge. And I remember in my career when executives and other clinicians just began to come into the nurses' lounge, the doctor's lounge, and doctors around me were pitching a fit. And I thought, yeah, what's the big deal? But I'm not very social and I'm a hardcore introvert, so it didn't matter to me. And I like everybody, it didn't matter. But truth be known, I've heard more and more about it since that time, that physicians lost the place where they can come together and commune and have fellowship. I experienced it firsthand last weekend when the members of the board of directors of Practicing Physicians of America flew to Chicago and got together in a boardroom for a day for the first time. We've been doing all of our work with a telephone for the last 2 years. And to see each other's faces, to experience each other's emotions, to embrace each other, to share a meal together, to go for a walk together, was the most nourishing experience I have had in so many years. I couldn't believe it. And I'm a hardcore introvert. And I was convinced at that point that physicians need to have a gathering place where they can experience community, fellowship, be human, and not under the examining eyes of people who don't take on the levels of responsibility that we do, and that is holding other people's lives in our hands on a daily basis.
Yes. You know, and I'm so glad you brought that up too, because that is one of the interventions that we see that is evidence-based and works, and that is peer support. And that's something that, you're right, we don't really have access to that. Even within our own circles of colleagues, it's how much do you feel comfortable saying about what's going on for you? But you know, everyone is having those experiences that are, you know, affecting you.
You don't know that. You think you're alone.
You do think you're alone.
And so we've been siloed and isolated, and we've been threatened, and we are fearful. I have been there,
Yes.
done that, waking up in the middle of the night, shaking, sweating, wondering, knowing that things were going to change, and believing that I was the only one experiencing that.
Right. And I think every one of us has that experience. It's lonely and there's a lot of pressure, and we just need to come together. And I promise whoever's listening, you are not alone. You're not. And that is actually something that mainstream medicine is doing. And it's going to be virtual support groups, which are conducted like this, actually, but in kind of a different setting. And it can be anonymous, and it's screened by me. Everyone is screened by me to make sure that everyone gets into the correct group, because I think that is something that's really valuable, and it's something that isn't happening. And so we're in alpha testing mode right now. So that should be announced pretty soon. So.
Well, thank you for what you're doing. David, we need to get together in person, physicians as a whole. And I know you know that. And so John, this is a wonderful opportunity. Thank you for providing it for us. And when we get together, I would like to us not see session after session after session where we are, well, what I do want to see is the opportunity for fellowship, community, rest, relaxation. I think if you take this group of fatigued individuals, you give them some rest. I got off on my sleep thing earlier, which is very, very important, by the way, to mental and physical health. You give this group of people some rest, some nourishment, some fellowship. I'm thinking 2 or 3 days. You are going to take what I call a herd of cats and transform it into a pride of lions. We're going to understand our value. We're going to understand our power. We're going to start using our keyboards and our pens and our stethoscopes to interface with these profiteering executives and begin to move the needle and let them know that we command the practice of medicine and not them. But I also think that we're going to be a comparatively smaller group than we have been before, but we're also going to be a group with minds and spines. The ones without minds and spines are going somewhere else.
Yes. I guess, so we're almost out of time, but I just want to also point out that physicians and patients we're all out for the same goal, and that is amazing patient care. And so really all these intermediaries who affect the relationship between the physician and the patient, we don't need them. That's the beauty of direct care. And of course there are hospital-based specialties, but I think eventually we'll be able to make sure that's more direct too. So, and also the struggle of the primary care physician, I think is another big thing that we need to address, because man, they are not appreciated enough. I appreciate you. There's so much good that can be done, and I look forward to seeing that happen. So I think we'll end there. Yes, I agree with you. We don't need no stinking intermediaries.
So guys, if we don't have another couple of minutes and say so, I'm a surgeon and a breast cancer surgeon, and I need a lot of support for what I do. And I'm frankly dependent upon the system. And when a person has a diagnosis of breast cancer, any other type of cancer or catastrophic illness, they need their insurance plan. And so, you know, we don't need to go off on how insurance plans have gone awry. But I have to learn to get along with the system, which for the foreseeable future is going to continue to be here. I've got to learn to do what David said, understand my value and understand my power and be a meaningful contributor. And what I want to do is, again, stand on the shoulders of what those people, those tools and services that the system provides to patients for what they need to treat their illnesses, rather than feel like I'm carrying the system on my own shoulders. But that's an intellectual, emotional, spiritual, professional paradigm shift that takes a lot of work. Hey, can I just quickly show people some books that have been very helpful? Is that okay?
Yeah, for sure too. And
Marty?
I think, am I muted? Oh, sorry, Dr. Judy. Hey,
No, you could.
there's a couple questions that I'm not
Go
sure
ahead.
got addressed there. Do you see the Q&A option? I mean, I think we've been reading that.
Yeah,
There's a couple down there by Dr.
Oh,
Sussman.
okay.
And also the student shortage. I think that's something to be addressed, because you're seeing a lot of medical school students choosing not continue just because they're already burnt out. And that's something that really needs to be addressed.
Really does. And GMA funding needs to be expanded. Absolutely. That was frozen in what, 1997?
So when I went to medical school in 1986, I was bombarded with, why are you in medical school? It's not worth it. So it depends on what your values are.
Yes.
And it depends on what matters to you. Now, I think one of the biggest problems that medical students are facing right now, and it's not something that I've delved into, is the mismatch between the debt that is generated getting through school and what they can anticipate to earn. That's a financial non-starter. I think that needs to be addressed. I think that people who love caring for people and people who think that that's the most wonderful job in the world, and that to me that translates into prestige, need to come on, but need to understand that this is a very tough place. But if you're doing it for the right reason, I do think that you'll be okay. But you got to look in your own heart and look in your own mind and be clear with yourself about why you're doing what you're doing, and can you really afford to do what you're doing. And if you can't, then maybe you need to revisit that question or re-examine your resources so that you can get through it, so that you're not compelled to do something that you don't want to do just to pay the bills. None of us want to go through all of that, all of this to be in that situation.
No way. And I would say I agree with you up and down. Like that's if a person is considering going into medicine for financial security or financial reasons, bad idea, really bad idea. But if you're doing it for the patient care, that's what's going to get you through it. Otherwise, it's untenable these days.
Another question, look how physicians came together when a malpractice crisis hit California in the 1970s and MICRA came about. Why not arrange a trip to Washington in the spring on the same day, accost our congressman, and take no prisoners? Our livelihood is at stake. That's Ernest Sussman. Thank you very much, Ernest. Well said. And we have done that several times. I suspect that we will continue to do that. If you will become a member of Practicing Physicians of America, which there's no expense to you, again, contributions needed and appreciated. We will keep you informed when we're meeting. We've held some very, very nice meetings in the Library of Congress where Marion Mass, who has entree into the halls of Congress like nothing any one of the rest of us have seen, and she will teach you what you need to know to prepare yourself to meet and have meaningful impact with your representative. But we've done it before, we'll do it again. And thank you for that comment. Marnie, is it legal for potential new employers to ask about prior mental health treatment?
Well, in some states, that is a question on the licensing applications. In other states, it is not. So we're moving toward the question, do you have anything that is currently impairing your ability to practice medicine? And elsewhere, it's directly adjacent to the criminality section of the application. So that is something that we need to fix. And physicians' licenses are in jeopardy sometimes. And even if it's not an immediate concern, it's always a grain of doubt. And that's scary. And so then people don't get the help that they need. And that is also scary. So, well, it is 1:59, so I think we should wrap up, but thank you all so much. Thank you, Dr. Thompson. It was a pleasure.
Thank you, Marnie.
Yes, thank you both. And thank you all for all the questions. And I was very informative. And Dr. Judy, you got me fired up about coming together.
Yay.
You have my support as always. And that's what it's going to take, is everybody coming together and united to make some change. All right, well, thank you all. And now I will stop the video for you all and bring on our next panel. So have a great rest of the afternoon.
And you. Thank you so much, Brennan.
Thank you.
All right, our next panel is on the topic of political engagement. And we have Dr. Marion Mass is going to moderate this one, along with Dr. Bob Campbell and Tom Oliverson. And I am adding on everybody now. So why is my face on there? Let's see. All right. take it from there. I will step out. I just added, let's see here. I think, Dr. Bob, you got your camera is off, and let's see, Dr. Oliverson, your camera is also off. Oh, that's why my face is on there. I was testing it out on my phone. All right.
I have my audio.
And let's see.
It says the host has disabled it.
Yeah, I did that earlier because we had everybody on there. Now, there you go. All right, everyone. Well, Marion, I will let you take it from here and I will step off. Thank you all.
Wonderful. Thank you. I got to listen into the tail end. Welcome to my car parked in the middle of the Bronx in New York City. I went to my son's cross country meet this morning. So real life here happening. Great panelists before, Dr. Thompson and Dr. McGrath. You guys did a fantastic job. And I think it's a real segue into the topic that we have here. I think that one of the most empowering things I've heard other physicians tell me, or one of the things that they've found most empowering, is starting to get involved at the legislative level and understanding that they really do have a voice, and that legislators are interested in hearing what they have to say about their patients, about their practice, about the future, about ideas of how we can make our profession better. So with that said, I'm going to introduce our two panelists. State Representative Tom Oliverson is a practicing anesthesiologist and a Texas state rep. Dr. O is recognized as an expert in office-based anesthesia, and he consults with doctors and dentists throughout Texas to make office-based surgery safer for his patients. As a successful small business owner, he understands small business as the engine of our economy. He's active in organized medicine through the Texas Society of Anesthesiologists, and he's authored as a state legislator over 120 bills during his tenure in the Texas State House. So what a great opportunity for us to have an actual legislator who is a physician on board this panel. In addition, we have my friend and colleague, Dr. Robert Campbell, who is certified in both anesthesia and pain medicine, pain management. He practices in Lebanon, PA, and he's co-founder of Physicians Against Drug Shortages, a group that advocates to decrease drug shortages and lower costs by repealing the safe harbor for legalized kickbacks that's part of the drug supply chain. In addition, Dr. Campbell's active in Physicians for Reform, and he's the past president of the Pennsylvania Society of Anesthesiologists and a delegate to the American Society of Anesthesia. And in case you didn't know, our anesthesiologists are really gangbusters in terms of advocacy on surprise billing, on matters of scope of practice, and so many other issues. He has experience in crafting legislation and extensive experience in meeting with lawmakers at both the state and national level. And when we planned this panel, we decided the first thing that we could do, and I do this in the spirit of, I really do, there's a lot of distrust for lawmakers. And I think that I do view what they do as a public service. And I think in that spirit, I'd like to hear from Dr. Oliverson, to hear what his path was from medicine to becoming a legislator, and it might open up some eyes as to what you go through to actually become a legislator. So take it away, Dr. O.
Thanks, Marion. See, I can't see myself here. Can you all see me okay? Okay.
You're looking uber professional, especially compared to
I'm still the little screen on the little box
shot.
on the top of the screen, and I can see you very big. So I was just like, I wonder if, how that's working. Anyway, no, I appreciate it. Look, it's, I don't think it's for everybody. My journey, though, began when I became the guy who was sort of in charge of office-based anesthesia for our group. And what happened was the Texas Society of Anesthesiologists was dealing with some issues with the medical board concerning regulation of office-based anesthesia, and they needed an expert that really understood the business well. And so I volunteered, and the next thing I know, I'm sitting next to the president of the society and basically leading the discussion and providing comments and feedback. And I think it was probably about 9 months after that, I was working with a couple of legislators to file legislation to sort of close a few very bad loopholes where somebody could give a milligram of Versed and they had to be registered with the state board, but they could give a toxic dose of local anesthesia all day long and they didn't have to do anything. And that kind of got me interested. I like to tell folks that, you know, the decision to run for public office is not one to be taken lightly. It's not one that I really looked forward to or really wanted to do. It's not something that I had grown up thinking, gee, it'd be neat to do that someday. And part of that, I think, is what Marion said is, you know, there is some frustration around the fact that what you read and what you see, you sort of get this impression that public officials are not necessarily out there doing the best they can for the public as much as they're doing it for themselves. And so it was kind of a process for me. I ended up finally meeting some folks who were serving in the legislature who convinced me that, you know, that there was room for somebody with, you know, the right moral compass and the right ethics to be involved, that there was a place. And, you know, most importantly, I spent a lot of time in prayer about it. And I think this is one of those things that if God calls you to do something, then you're going to be equipped to do it and do it well. And I certainly felt like that was the case for me. So an open seat came up. My state legislator retired. I remember running in that race. It was my first ever real political experience outside of basically being a patient safety advocate and, you know, sitting on that side of the desk and advocating for good healthcare policy. And, you know, God smiled on us and we prevailed with 70% of the vote. And since that time, you know, I've enjoyed representing the people in my district on a variety of issues. And I guess the last thing I'll say is I think we get so used to dealing with healthcare. I think one of the things for me that was a big wake-up call is when you get in there, you realize that you're knowledgeable about only a fraction. By that, I mean less than 1/100th of the issues that you're likely to have to vote on. And so you drink from a fire hose literally for the first year that you're there, trying to understand all of the policies and issues and things that you've never even thought about as a doctor. So I think that speaks to a large portion of why what we do is so important, because there are just so many legislators, it's not their background and they don't know. They don't deal with healthcare. So unless we're educating them, they don't know.
Fantastic. And Dr. O, and I hope it's okay that I say Dr. O, it saves me 3 syllables each time.
You can call me Tom too, that's fine.
Okay, even better, Tom. It still saves the 3 syllables. So if you had to tell physicians like 3 things that you want them to know about what it's like to walk the path of running for office and serving in office that they may not know. You know, I mean, like patients come to us and they have their concerns, suggestions, worries, and you know, there's things that we wish that they knew. What do you know now as a legislator that you'd like to tell physicians?
Yeah, I think so. Great question. I think a couple of things. It is going to take more time than you think it's going to take away from your practice. No matter how well you plan it out and do the calculations in your head and say to yourself, I think I can do this. There's always, especially during campaign season, there's always events and block walking and vote getting, you know, things that you need to do to get your name out there to win. I ended up having to take 4 extra weeks of vacation the year that I ran in the primary. And that time was literally spent from sun up till sundown, knocking on people's doors, you know, discussing with them who I was and why I thought I was the right guy to represent them in Austin. And you know, the time investment is humongous. And I think that's obviously a barrier for a lot of physicians. We don't realize at the time and how much time that it's really going to take. The second thing I would say is doctors notoriously have thin skin when it comes to people being critical of them and you know, questioning their knowledge or their authority. And I think if you're going to run for office, you've got to develop some thick skin very quickly and realize that, yes, people will lie. And yes, sometimes people won't lie. They'll just say something that's not factual, but they believe it so strongly that there's nothing you can do to convince them otherwise. They will go on Twitter and Facebook and say nasty things about you. And you just kind of have to let that go. You have to resist the urge to engage with every person. I know a lot of doctors that get frustrated when patients come into their office with something they read on Google, and don't confuse my medical degree with your Google search kind of stuff. That's a everyday occurrence when you're a state representative, or certainly the federal level. You constantly have people questioning everything you do, even if it's something that they know that you should be super knowledgeable about, because at the end of the day, there are people on the other side of that issue, and they don't want to see you win. Even if it's the right thing, it's not good for their business, and so they want to prevail. So I think I'll stop there. Those are the two things I can think of that are really important, I think, for folks to know.
Okay, wonderful. I do see some questions that are coming up, and I think that particular one can, we do have like a kind of almost like a plan, so I think we can answer as we get towards the end of our some of the questions. And I think personally, from what I've seen in advocating at the state and the national level, our voices are needed now more than ever. Would you agree with that as a lawmaker?
Oh, unquestionably. I still, in my home state, I am the House author of the surprise medical billing bill that we passed in Texas, which was very much more fair to providers than what is currently being proposed in Congress. And when I, as a legislator, go and educate folks at the federal level about the issue, I'm always surprised. Now that the staff knows the issue quite well, but the legislator just may not. And so I think it's critical. I really don't think that people understand very much what it is that we do and how these laws, the unintended consequences of these ideas that are being presented may actually harm not only patients, but actually harm the entire healthcare system. So our voices are critical. And I would say as a positive to that, look, at the end of the day, you're still a physician. When you show up, especially if you're wearing your white coat, people are inclined to hear what you have to say. They want to hear what you have to say. You are still a representative of one of the most respected professions as far as careers that there is. And I think that you do have a certain amount of credibility as a doctor when you come in and say, well, let me tell you how this would really work, how this would unfold. So yeah, absolutely. Couldn't agree more.
Agree. And I want to switch over to Bob, Dr. Campbell. And Bob and I have done some advocacy work together. And, Bob, has this been, what's been your experience of what you see when, because you and I have both taken younger physicians in to become advocates for the first time. What's your perspective of what they find out and how they see it and their response to going?
Yes, Marion, thank you. My name's Bob Campbell. I've been in Pennsylvania practicing for 31 years. And I've been involved in advocacy really since 1999 at the state and national level. I've learned a lot over the years. Some of it is what Tom had said. He said it takes a lot of time to do advocacy work. The other thing is whatever issue you are striving to work on, it's always going to take more time than you can imagine to come to a conclusion. It's just the way the process works. I call it kind of a trench warfare. The other thing that I've noticed consistently in my involvement with advocacy is that we just don't have enough doctors involved. I often hear, I was in a senator's office one time and I asked the guy who took the phone calls, how often do you hear from physicians from the state of Rhode Island? This was the senator from Rhode Island. And he said, never. He says, you guys never call. So sometimes that can be to our advantage because we've been so underrepresented. If we find people who are willing to step up, even if you take a week from your practice and plan it out and put in a good week's worth of work out of the whole year, it will get noticed. And that's an important thing. The third thing that I've noticed, and I'll give you an example of that right today, is networking is so important. And Marion and I got to know each other and have done some things that I could not have done without her. And Dr. O, I've been involved in balanced billing in Pennsylvania for 3 years. So I'm going to introduce you to our team. and there we're going to network.
Sounds like a great plan.
Yeah, and you know, so the networking part, I've always been able to find that the doctors, those few doctors who are involved in advocacy, will step up. They really will step up. And of course, the problem is getting more people involved. I'll leave you with one other little bit of advice is that the thing that I've been very impressed with Free2Care. You know, I say there's 21 member organizations, 2.3 million patients, 37,000 physicians. Our biggest weakness when I do advocacy in Pennsylvania or in Washington, D.C., is that we do not have a cohesive, organized voice. We just, whether it's egos that keep small organizations small, or our inability, our extreme desire for autonomy, for whatever reasons, we've been able to come together. And I think for the first time ever, I've seen things have gotten so screwed up, I'll say, I could use worse terms, that doctors are finally kind of realizing, hey, we either have to come together or we're all going to be toast. And that's what I tell people in their organizations. You can stay small, and in balanced billing, we've had multiple specialty groups who want to splinter off and do their own thing on balanced billing. And I say, if that happens, we're all toast. And so we've been able to keep people together, but it is a hard thing, an impulse that physicians have. So if Free2Care is that vehicle, or maybe the best vehicle to date, time will tell. I think it's really, really powerful what they've already done. Where all the different coalition members, and I'll put out a challenge to the coalition and to David and Citizens Health and everyone. We've had some pretty impressive letter writing campaigns. I'd like to see if we can even step it up another level. And if we can plan and coordinate these letters, I'm telling you, make a huge difference. And if we can get people, if we can get 3,000 people in 1 week to sign on to a letter, maybe with 2 weeks, let's try to get 10,000 physicians. It's something we have to work on in the infrastructure. And that would be a way for Free2Care to really, really raise the bar for physician advocacy. Thank you, Marion.
Oh, super. Okay. All right. So as I expected, we'd be a little desultory here, and there's some questions coming in that I hope will be helpful as well. Our next portion was to actually go through tips that would engage and maintain relationships with physicians at both the state and the national level. But I think what I'd almost like to do as I'm hearing this discussion go on is describe a process by which physicians can become involved. You know, my question to you, Bob, was like, what have we seen when we, you know, take physicians down to Washington, D.C.? And I'd like to give my response to that. It's the whole, I asked the question because I thought it was a definite good one, and I'd like both of us to get our take on that. And, you know, what I have seen is, you know, and I'll give my own experience. The first time I went to Washington, D.C. in 2015, I was intimidated. You know, I was thinking to myself, wow, you know, all of these lawmakers, they must know oodles about healthcare, and I'm not really going to have much of a voice. I don't know if I'll get to speak, et cetera. Is this going to be worth it? But I'm going to go try and at least see what it looks like. And, you know, I don't mean any disrespect, but I got to DC and I thought, oh, wow, we should have been here a long time ago. And it isn't, I think healthcare has become so complex. I've had lawmakers tell me, we don't really understand. This is an issue that intimidates us. So starting small and making yourself available, forming a relationship with your lawmaker at your state and your national level. Find time when they're back in their district. It's no secret. You can go on to your state level and the national level, congressional and senatorial level calendars. Just look them up, Google them, and you can find out when they're back in the district. Look for some times that you're available and ask for a meeting. You know, something else that helps is if they happen to have events coming up, you can certainly ask the staff when you call, is there anything that I could attend that would make it easier to open up the door? And then, you know, present yourself as an advocate. If you're part of Free2Care, to step forward and to say, hey, I'm part of a larger organization that encompasses 37,000 physicians and 2.3 million citizens. That means something. And, it gets people's attention, and then you make yourself memorable. One of the things that I've learned in going into offices or in starting a relationship is that I'll go to their websites and they all have a bio, and I try to find some point of connectivity or some point that relates to the issue that I mean to go to talk about. Bob, you brought up signing petitions and signing on to letters, and that is certainly a really helpful way to make it happen. But I do encourage everyone within earshot here to be persistent in trying to get yourself to an event or to a meeting, to start to form the relationship so that they can see that you're real, that you're genuine. And you have to think about, how can I make myself indispensable, useful, and helpful to this person so that we open up a conversation and we can have an ongoing established communication network. Dr. Tom, do you want to add anything to that issue about forming the relationship?
Actually, I think the reality is that these relationships best begin before you ever have an issue that you need to talk to the legislator about. The reality is, at the end of the day, what we all want is to be a point of contact or a key contact for that legislator. Your goal should be to have your cell phone number and your name in their phone so that when you text them, they know who it is. Now that may seem like a tall order, but the reality is if you wait until you go to the Capitol Hill or you go to your state legislature and you're meeting them for the first time, you're already behind the 8 ball. What you want to do, I believe, is get to know the legislator back home in the district, make time to learn about their positions. If they're a person that you feel like you could support, then do so. Help them raise funds for reelection, work on their campaign. I will tell you that I meet with tons of folks, and I don't remember, everyone I meet with, but I know the names, faces, and backgrounds of anyone who's ever spent a Saturday with me knocking on doors, trying to get the vote out. I mean, there are things that you can do as a physician to really maximize the ability to have that relationship. Every human, legislators included, only has so much bandwidth to be able to take in information. So when you sign on a letter and a petition or whatever, all of this is helpful. But what you want is to be the person in the district that legislator reaches out to when they have a question. Let me give you a quick example of how this works. So my first session, I've sat on the insurance committee since I've been there. And our first session, we had a bill that had to do with title insurance. Now, I don't know anything about title insurance other than when you buy a house, you need to get it, right? We had this bill and it was brought to us and it sounded kind of good. It was talking about deregulation, it was talking about competition, and I'm a conservative guy and those are kind of buzzwords for me. And then I got a call, and it was from a gentleman that I knew in the district. He was a realtor, but he also had a title business, and he proceeded to explain to me how this bill would impact his business back home. And the reality was, it completely changed my view on that particular piece of legislation. I voted based on the fact that I knew I had constituents at home and this was going to adversely impact their business. It was going to cause them to have to lay off employees. It was going to have all of these unintended negative consequences. And it changed the way I looked at that legislation. At the end of the day, that's the relationship you're looking for, but you have to start. Now is actually the best time to start, right? Re-election campaigns are gearing up. People will be running in 2020. Every member of Congress is up for re-election. I think most members of the lower house of your state are probably up for re-election. Some of your senators are. Build that relationship outside of advocacy first. That way, when you need to be an advocate, they know who you are, they remember, and it's not something that's just sort of, yeah, it was a nice meeting, we'll look into it, we'll see you soon. You have a personal relationship with that legislator.
Great point. And I want to tie it into some of the things I'm seeing on the chat. Someone brought up that the legislative system is not accessible to physicians' schedule. When hearings happen, if physicians want to testify, sometimes they're brought up in 48 hours notice. It's very frustrating. Even physician legislators don't have a lot of time to talk to individual physicians about issues. That is one of the points we bring up, having the relationship so that you can become almost the trusted one, where you're texting them and letting them know what you're seeing out there, so that you've already built that time into making that relationship. And I mean, if I, as a part-time pediatrician and a soccer mom, could manage to do that and have that textual relationship, I'm sure you can too. It's just, it does take some time to build that up. And it's also brought up here that we're getting completely out-donated and out-visited by lobbyists who are working for, quite frankly, things that are important to us and our patients. I agree 100%. Part of the idea behind Free2Care would be that now we have a big network of physicians. If all of us start working at our state level, our national level, start building those relationships, make those visits when we can, and if we in tandem are all saying the same things at the same time. You know, for instance, we're going to hear, I believe tomorrow, House Bill 3708 is not going to be helpful to it's going to be very toxic to the DPC community. And many of us have made phone calls. We're doing it all at the same time when the issue comes up. And we're looking at legislators who are hungry for information on healthcare, because many of them don't understand it. They're frustrated and they're confused. And if they're hearing all the same thing from many of us, that's a way that we can get information out there. I know other groups do this. At PA, we try to send email notices to our membership to say, hey, we have an action item. We want you to call your legislator right now, and here's what to tell them. Here's the background information on what we're seeing. So even though we're not able to necessarily be there and testify, at least making those phone calls and trying to make them stack on top of each other. And it's not only important that you do this yourself, but find some friends in your physician community and your patient community that are willing to do this along with you.
I was looking at the chat. Can I add one thing with regards to that?
Sure, please do.
So I'm seeing a lot on the chat about, you know, lobbyists and physicians not having, you know, time and stuff like that. Let me just assure you, as an elected official, that constituents always outrank lobbyists. It doesn't matter whether the lobbyist has, quote, you know, 24/7 access. They don't. And at the end of the day, it doesn't matter what the lobbyist wants a legislator to do, or whether they, you know, are going to support that legislator financially or whatever. At the end of the day, no legislator in their right mind wants to go against the wishes of their constituents. Constituents always outrank lobbyists. But the thing is, you don't want to just be a constituent. You want to be an activist. You want to be somebody that shows up. You want to be somebody that follows the vote. You want to be somebody who they count on for help when they're running for re-election. It's that relationship that you can build. But yeah, don't be discouraged about the whole, you know, lobbyist thing. They get paid to do that. But every single one of us knows that they're getting paid to basically say what it is they're getting paid to say. That's never going to be the same as a heartfelt testimony from a constituent.
So Marion, if I can step in here, sometimes with physicians, and I've seen a lot of the chat room material, you have to kind of find your place. So let me give you my ABCs of advocacy. You need three things. You need a grassroots network. And what that grassroots network means is, for instance, in Pennsylvania, we have 50 state senators and 201 representatives. So what we try to do is have a physician have a relationship with each one of those members in the districts. And kind of like Tom said, not when you need something, but just here's my card. I'm a go-to guy if you have a question. The way I usually introduce myself to a legislator, and I've had a lot of new ones in the state because of redistricting and different other reasons, But I always try to tell them one thing that I think will impress them. Like one thing would be, I'm a member of Free2Care representing 37,000 physicians. And then after I tell them something to impress them, you very humbly say, look, I'm a constituent and I'd like to be here for you if you need subject matter expertise. If I don't have it, I'll find somebody who has it. And they appreciate that because a lot of them have to deal with so many issues. They don't know a lot about healthcare. So the first thing is that grassroots. The second thing is you have to have a lobbying platform of some kind. So Free2Care, for instance, is one. I'm a member of the Pennsylvania Society of Anesthesiologists, the American Society of Anesthesiologists. Those organizations have lobbyists, and you need an organized effort that then triggers the grassroots people to get involved and how to do it, when to do it. And then the last thing you really do need, and you don't need a lot of this, but I always tell people you do need a PAC. So if there's a new senator that comes into the state of Pennsylvania, I show up with a $250 check. Hello, I'm here to help you if you need help understanding healthcare issues. And that $250 check goes a long ways with a new state senator. It doesn't take as much at the state level. At the national level, there's a higher bar for that. But those are the three things you need. So when you're thinking as a physician, what can I do? Don't get overwhelmed and say, I have to be in Washington whenever they call or whenever a bill comes up, or I have to go and meet every senator or every congressman's staff. Now you have to find your niche. And again, the thing we've been missing is a large organized effort. And I divide our organizations, physician organizations into legacy and grassroots. And our grassroots members, which are really the majority of the Free2Care, they really have the ideas, the motor, I guess Jane used the term, the minds and the spines. Some of the legacy organizations are, I'm going to be very honest, they're a little bit lame and they're a little more self-introverted as far as their own motivations. So find a platform for lobbying that you believe in, and maybe that's Free2Care, maybe it's something else, but get involved with that, and then get to know your legislator. Now, I'll tell you one other thing that I'll do, and then I'll hand it back to you, Marion. An idea I had years ago is every time we have a new legislation and a new legislative session in Pennsylvania, I host a dinner. And it's fun. It's paid for by my Society of Anesthesiologists. And I invite all the Republicans to one dinner, all the Democrats to another dinner. I give them a brief presentation and mostly say, I have resources, subject matter experts on healthcare. We've not had a legislator in Pennsylvania who is a physician since 1972.
Wow.
So they appreciate that. And what happens is you do that every session, whether you have something hot on the burner or not. Now, then when something really white hot is present, like balance billing is now, we can come in with an established relationship, subject matter expertise. And the one thing that the people always tell me is that we appreciate physicians for what you do and the fact that you are one of the few institutions that has not been succumbed to the entire corruption that seems to be ever present in advocacy. So we have genuine voices. We may have small voices and we may not be as organized, but they really do listen. They would listen more if we can get Free2Care to be 100,000 physicians. But let's get there. Let's use what we have now. Find your little niche. Don't get overwhelmed. You don't do it all. Whatever you don't do, we'll assign it to Marion and she'll follow up. Thank you.
Well, I'm going to follow up right now with a couple of questions from the Q&A because I don't want them to get lost in the shuffle. Someone asked, in spite of my efforts and reputation, my congressional representative and senators have yet to respond to invitations to meet with them. And thought is offer them several options, opportunities, and I think I would try to attend an actual meeting Sometimes they'll hold open houses. If this is something that you're in the position to do so, call and offer to come to a campaign event if it's something that you feel spending money on. I do understand certainly don't necessarily want to donate to someone they don't believe in, and I certainly respect that. Came up. How do you effectively influence lawmakers in an environment that is so partisan? Is it worth trying? I think that as one of the, that is exactly what I tried to do, because I think right now in healthcare, I think both our patients and the physicians see that there's so much that needs fixing. Efforts in that paper were to put together solutions that were all aisle crossers, and the major topics certainly fit that, and to that had bipartisan resonance. The other legislator is, it's worth meeting with them. I meet across the aisle all the time, and I think that it honestly gives us as physicians more credence and more respect to try to get ideas out there, because healthcare is personal. It's not about ours, and it's not about these. So I think that's definitely worth trying. And the other question that I didn't want to get lost in the Q&A was specific to you, Tom. It said we had a surprise medical bill pass in our state. It didn't cure the problem, put the onus on the Division of Insurance.
Yeah, let me answer that one specifically. Yeah, so we do communicate with the Department of Insurance. I meet periodically as a legislator with the Commissioner of Insurance, and I have a very good working relationship with the insurance department. And our legislation in Texas does use arbitration as well. It's very similar to New York in that respect. And we're in the process of implementing some changes to it and sort of expanding on it right now. So it's something we are meeting with them periodically. Yeah, good working relationship.
Okay, excellent. I'm going to go through some other comments that are in here, because I want people to hear what them beyond the benefits of patients, the profession, and our nation. Agree 100%. In the previous discussion, Judy was talking about how we're not getting together. Whenever I've advocated and done so with a group of physicians, just that magic to me to watch people who have never been involved get involved and the light bulb go on. I'll actually give as a personal example. I took 3 younger women physicians in. They had a meeting. The one that arranged the meeting said to me as we were going, "Well, you're going to lead, aren't you?" I said, "Absolutely not. You got this." And I think she was a little reserved. Watched her go into turbocharge. She understood her voice was needed, and I think it's empowering. I think it's a little bit of an antidote to burnout too, to tell you the truth. Another comment: research indicates healthcare is the number one concerned about. It's a priority for our citizens. Agree. Mentioned several times, physicians are confused about the issue. We not only run through these 8 points. And those are gold, because if you can tell a story that's relatable to the general public, if you can tell that to a lawmaker, you're really touching on the point. You're making healthcare understandable to them. You're making it human to them. So I think that's not under the gun. If you're only calling when you need them, it's less effective. Get to know them before. Someone else brought about bringing a set up, if they felt so compelled. Let's see, someone else brought up it's important to bring a talking tear sheet to hand out to our patients, so that patients understand what they had to advocate for. And I think when we hit crucial points, whether it's at the state level or at the national level, that's a great idea, is to be able to hand something out to patients and to say, and to leave them with the number. Whenever I put something out there for PPA, I try to leave them, I do it in the following manner. Urgent, we need your action here. Here's the issue. We need you to call your lawmaker. Here's a place that you can go. Your zip code, all of your state and national level office numbers, which has really helped. Something like that to hand out to patients is really helpful. And I will say that anything we send out to PPA like that, you can certainly share. Let me see. Someone asked, what's the best way for grassroots physician advocacy groups to work with national and state medical associations? Do either of you want to field this, my panelists?
I could do that. Volunteer to be a grassroots champion with your state senator and your state representative. And that's where you go and you meet them. And don't go specifically with, oh, I need you to do this, but go in the home district when they're in their district. You can almost always get a one-to-one meeting in that way. And then when the state organization needs you, they have you on their database that says, hey, we have a bill that's coming up next week. Can you call this office and tell them who you are and how you want it to vote? The other thing that is kind of neat when you want to meet these people, you need to have interesting conversation. And one of the things I do typically is I'll look in the news on things, and it gets to what Mary was talking about, bipartisan and taking away the ugly politics. So like if I were to go and meet someone today for the first time, I would go in and I would say, and this just was in the news today, you know that we have over the next 6 years, cancer rates are going to increase by 40% in America with our aging population. 40% increase in new diagnosis of cancers. You know, we anticipate a shortage of 2,200 oncologists over the next 6 years. So again, you get to the point of physician well-being. The system is broken. Do we want the best and the brightest? Do we want good healthcare delivery? We're paying more than ever, 18% of GDP, but we're getting less and less care. So sometimes you take a news hook. Those are things that they want to know because their constituents, non-physicians, general constituents might be reading that very article. So that's another way to kind of have conversation and make yourself relevant. So yeah, start out, be know your representatives. All you got to do is meet them once. They'll remember you. Trust me, they will remember you. We had someone here in Pennsylvania, Joe Galassi, who met then Senator Toomey when he first became a state representative, worked his way up through, and to this day, Senator Toomey, we'll always remember Joe for being there when he was a nobody. And so to this day, we can get in with Senator Toomey when we need to, just because of those relationships. So those are the little things. It's more relationships and discussions, and you can't do everything, but you can do your small part. Thank you.
No problem. We did have a couple other tips that I wanted to add in there, so that when you do start to form that relationship, some particular tips. Did you want to speak, Tom, to it's really important, the staffers, and Tom, I think you said this, it's even more important at the national level, getting to know the staffers, because oftentimes they're the ones writing the legislation. So if you know the healthcare legislative assistant, that's in some ways more important than knowing the congressman. And I always tell people when you get to DC, they're often disappointed to find that they're not meeting with the actual lawmaker. It's nice for a photo op, that's great, but really those staffers are important. Tom, do you have any more to comment on that?
Yeah, Marion, I think you're right on. I think that, it is one of those things that I have literally seen this go sideways where a group comes in. It was funny, actually. I was there pretty recently talking about surprise medical billing to one of my senators, and a group came in and they had a meeting with Senator Cruz, and things come up. He had to go to a budget hearing or something like that. And they just became totally unhinged about it. Well, we had brought a constituent with us. Why can't we meet with the senator? We don't want to meet with the policy person. Well, the policy person is the one who's going to advise the senator on how to vote on that issue. Even at my level, there are things that I'm working on personally because I know a lot about that area. But there are things that my staffers basically advise me. They take all the meetings and they advise me. If it's something like water, flooding, infrastructure, stuff like that, that may not be something that I'm super gifted at or knowledgeable about. So they're gonna take those meetings for me and they're gonna advise me. So I mean, yeah, it's very critical not only to meet with the staffers, but to be gracious. Don't act like all put out because you can't meet with the member, especially at the federal level. If they're actually there, which is becoming a shorter and shorter window during the week. They've got about a bazillion things going on. So the staffers are really, really, really critical in those meetings. I would agree.
Wonderful. Another tip that we had come up with, it's really important when you advocate to make it about the patient first. I don't know how to say this any other way other than, unfortunately, very few people are going to care about the plight of the physician, other than if we're talking about shortages down the line and how can we help that. But making your story get it back to the patient. I remember one particular meeting I was at, it was very high level. Someone had come in by phone and the issue they wanted to talk about was a reimbursement, and the reimbursements were falling and falling and falling, and this was a big problem. And they were coming in by phone. It was with the actual legislator, and just the look on the legislator's face just said it all. There was no way he was going to be interested in hearing any more about this. I think it's really important that what we make this about first is our patients. Comments on that, gentlemen?
Yeah, I mean, I think that's totally right. I personally, as a legislator, as a conservative legislator, I don't like rent-seeking behavior. And what I mean by that is I don't like taking meetings with groups when they come in and tell me that, they need more money from the government for this, that, or the other thing. And so what I want to hear about is how is this going to help the community? How is this going to help my constituents? I think it's always right to frame it in terms of how it's going to impact the patients. Now, that doesn't mean that you can't have a conversation about the fact that, going back to the surprise medical billing issue, because that's one we're all focused on. The benchmarking idea will cause me to go out of business, and that I may be the only primary care provider or anesthesiologist or surgeon in my community. It may cause my hospital to go out of business. And there's nothing wrong with sort of bringing those real world consequences to bear. But I agree. I don't think anyone likes to hear, the "we need more money" thing, because that's kind of what everybody likes to say when they come to Washington or to the state capitol is, we're not getting enough money from X, Y, and Z program.
Okay.
Bob,
go ahead.
Oh, I was going to say in that line, one of the points I wanted to make is when you meet with these people, you always want to put yourself in their shoes. And we come in with a great passion and it's an urgency, but you have to recalibrate. You can't be too aggressive, but you just have to really make your point. And one of the things that you can do to put yourself in their shoes is to realize they are inundated with lobbyists who come in, who have myopic visions, who have proposals that benefit them and their trade, that benefit them. And this is a conversation I've had with a lot of we have some people in the medical industrial complex who are starting to come around to repeal the safe harbor as a concept. And I say, well, yes, that would benefit you, but you need to have one other position that just benefits patients and not you, because the legislators really, I get this a lot, they call it the myopic, self-serving lobbyist who is just simply trying to get more dollars for their people who are paying their paycheck. So we have an advantage in that. We can talk about our patients. None of us are there getting paychecks to do this. So we have an advantage, and use that genuine, unconflicted perspective to tell the truth. And it will go farther than you think.
Yeah, agree. You know, Bob, this is kind of a tangential off of that point, but something that I see that often happens, and you know, in the way that people advocate, there's a lot of legacy organizations that are national level, built around specialty, and obviously one that's multi-specialty, you know, being the AMA. And there's a lot of them that are built around the state level, and there's a lot of state level. You know, you're a member of the Pennsylvania Society of Anesthesia, and the national level anesthesia. But I think that being part of the grassroots to be able to speak for what helps another group of physicians is really important. This balance billing issue is not going to affect me as a pediatrician, but I sure as heck see how it's going to hurt first the anesthesiologists, the radiologists, and the ER docs that are out there. And if they're not as available, then that's going to be a problem down the line for us pediatricians. And it's certainly going to hurt all of our patients. And then after those guys get the hurt put on them, it's going to hurt our specialists, who are then just going to be dropping out of ER call, and now we're right back at patients. So I think, and I was reminded of this week. There was a chat going on, and I brought up advocating to push back on House Bill 3708 that is going to be toxic to direct primary care. And someone brought up to me, well, you know, I'm a pediatrician, and that's not going to help me. Very few pediatricians do DPC. And that's true. I'm a pediatrician, and I did a lot of work to try to make this happen, because I think in the larger scheme, it's helping the sustenance of physicians. It's helping to make sure that we have a sustainable profession. So even though it won't help me personally, I'm willing to step up to bat for that. And I think actually it almost, if others start to see that, you know, pediatricians are willing to speak for specialists, and specialists are willing to speak for primary care doctors, we're helping each other, we're drawing ourselves together. And I think it'll encourage others to start to get involved. Because if it doesn't specifically matter to me and I'm still doing it, it's almost more worth something.
Yes, and if you follow the dots, if you connect all the dots, usually if there is something like House Bill 3708 or other policy that gets proposed, like balance billing, that physicians really don't like, that it hurts patients, it hurts us, usually it's from one of two groups. It's either the insurance companies or the health systems. So the American Hospital Association or AHIP. So sometimes, like with balance billing, that will greatly enrich the insurance companies. And so that which enriches the insurance companies, they are not always looking after patients' best interests. You know, they are in the business of making money off of a product. So sometimes if you connect those dots, you start to realize the relevance of it. So when I very rarely have I ever been in a setting where I've seen the American Hospital Association or the America's Health Insurance Plan lobby promote policy which would truly help patients. It usually truly enriches them. And they are the two big groups, and we are the little pawn, which needs to get a little stronger so that we can have a louder voice against those two powerful interest groups.
Yeah, agree. You know, and keep in mind, all those special interest groups, they never lose sight of getting what they want. They always stay united, and we must do the same. Is it all right, panelists, if what we do is just kind of wrap up? We have, I think, about 4 minutes left, and I just want to reiterate some points to hammer home, and then I'll ask you to respond to them. So what I'd like to say is that now more than ever, our voice is needed. For anyone new and young and thinking, I've never done this before, I feel a little intimidated, please don't be. because your voice is important, your experience is important. As a physician, you are exposed to a wide plethora of the human experience, and you have a knowledge from being insiders that will make you more knowledgeable about healthcare than most legislators in the room. It's really, it's just so crucial for you to get involved in having a network like Free2Care and the other grassroots groups that make it up. It's huge if we can find things that we can come together on and speak at the same time in the same voice. I think it really can turn the tide on crafting good legislation, on preventing bad legislation. And you know, as Bob, as you said, don't try to bite off more than you can chew. You don't have to be everywhere. There's a lot of us in Free2Care. There's a lot of us in other organizations. Get involved where you can. And when you do get involved, keep it in mind, it's about those relationships, not just with the lawmakers, but with the aides. When you speak, make sure that you're speaking about your patients first. We didn't mention this outright, but I do think it's important. A lot of people go to their lawmakers and they kvetch. It's important to come with a solution. Think it through. That's part of why we wrote the white paper. Your personal stories are a huge help. And lastly, the last two things I'll say is that I like what someone said. I think it was an anonymous question. Is it important to, to be bipartisan about things? Absolutely. Don't be discouraged if your lawmaker doesn't match your own party. And then lastly, keep in mind, you need to be patient. This is a long distance race. Legislation moves much slower than what we're used to in medicine. And those are my final points. Tom, do you have any to make yourself?
I think, you covered it quite well, Mary. And I guess, the things that I would emphasize is, again, if you really want to be an effective advocate, that should begin long before an issue comes up upon which you need help. You need to build a relationship with that legislator so that you're a go-to person for them. And that's not something that happens when you just walk in the door for a meeting for the first time. So I would encourage, there are precious few people in this world that volunteer on campaigns. I can assure you that if anybody listening to this was to call up their state senator or state legislator, or even their congressman who's running for re-election and said, hey, when are you block walking next on a Saturday? I'd like to come block walk with you for 4 hours. And, as a physician in the community, you will never be forgotten for doing that. You would put yourself in probably less than 1% of people who, express a position on an issue that actually are willing to help out somebody. You just can't ignore folks like that. So I think that's critical. We didn't cover some of the don't do's, so let me just throw those out really quick. Never, ever, 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 ever walk into a legislator's office and remind them of what it is that you did for them in the last election cycle. Hence, you really need their support on this particular issue. If you are there for them, that goes without saying. They know that. But if you bring it up as a matter of the conversation, now you've created that mysterious term that we're all looking for these days called the quid pro quo. And legislators will, recoil in horror from somebody who says, remember, I gave a bunch of money to your reelection campaign. I really need you to be with me on this particular vote. You can't ever say that when you're going in. Like I said, I'm going to talk, just briefly, the bipartisanship is important. Look, a lot of what we work on as legislators on healthcare, these are bipartisan issues. There are precious few issues that are truly partisan issues. You can, if you take drug price concerns, pharmaceutical drugs, I know something we're all concerned about, so your concern is that prices are expensive. So go and talk to your conservative, Republican legislators about, gosh, don't you believe in free markets? Isn't there a point at which a patent should run out and competition should enter into the marketplace? Talk to your Democrat legislators about patients who are making choices between paying their rent and getting their insulin. I mean, so just by crafting the message I've now hit both sides on the same issue. So there's ways to approach that with pretty much everything that we as physicians would be concerned about. So don't give up just because you don't agree with their position on abortion or Second Amendment or immigration or something like that. Stay focused on healthcare.
Fantastic. And with that, we are going to have to wrap it up.
Well,
But
hey,
I love it that we ended on a nonpartisan point. Yeah.
I just want to add something here. Our next two panelists are both with patients. So we have a few minutes if anybody wants to add on any other thing. Yeah, because kind of missing them.
Go for it, Bob.
Okay.
Well,
Absolutely. I love it.
You know, Marion made a point about just because something doesn't directly affect me. I was involved for a long time, you know, with colonoscopy reimbursement. And, you know, we eventually got to the point where now at age 50, everyone can get insurances are required to cover colonoscopy as a necessary service. And it, you know, in the long run, you learn from one issue, you learn about looking at it from a total healthcare expense matter. So if we get colonoscopies at 50 years old, it turns out our healthcare budget is less because we catch polyps before they become cancers. We improve outcomes. We give people longer lives. It's a win, 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 win. But when you will have people on the other side of the table, and specifically the insurance companies. This is, you know, we don't want to make this medically necessary. So there's always going to be someone on the other side of you. But if you come in prepared, if you do your homework and you've chosen a topic that you know well and that you truly believe in and you have facts on your side, you just go there. You go there. And you don't have to call other people names or make them look evil. You don't have to demonize them. These are little tricks that you learn over time. And even in an area where I'm not an expert, you know, I have had my colonoscopy when I was 50, and, you know, that's a good thing. In the end, with that battle, we ended up getting out of right field. Katie Couric came into the picture, and she had a lot of influence over a lot of the people in government, it turns out, and that won the day. You never know where those wild events are going to come that is going to turn it from, you know, trench warfare into a victory. But even though you don't feel like you know a subject inside out, you are a physician, and you have that aura about you. You are very, very, very well educated, and people want to hear from people who are well educated, and you know more than you think you know on a broad range of health. So don't let that be an obstacle. The other thing that I would say is I can't tell you how often people say, I just never hear from docs. I never hear from docs. And so be that doc that they hear from. Let them remember you. And, we need it. Even give us 1 week. And David Ballat, I give him a lot of stuff to do, more than he can probably get done, but he'll give you stuff to do. If you can give him 1 week, he can make you very productive. And so go ahead, put yourself out there, be brave. Whether you're young, you think you don't know a lot, they love to hear from young doctors, or if you aren't a subject matter expertise, we'll give you the reading material.
Absolutely. Brennan, do we still have time to? Yeah. Okay. Yeah. So and keep us, just make sure that you come on in when the panelists come on. Okay. Someone specifically asked, can Tom comment on establishing a relationship with your representative who you know is on the opposite side of a particular issue in medicine? In particular, she brings up scope of practice when your rep co-authored bills for full practice authority.
Yeah.
Is it a lost cause? Or?
I know the doctor who put that out there. I appreciate that, Patricia. So look, at some point, you kind of have to have a conversation with your legislator after you've visited with them a dozen times on the same issue, and it's clear that they're opposed to you, you know, every single one of us, you know, every vote we take can potentially have consequences. And so sometimes it is one of those things. There is a point at which, you know, continue to engage, but you may start looking for somebody else to do it better. And I know the specific issue that she's referencing, and that's tough. You know, sometimes we look for progress. Sometimes people will ultimately change their positions. Sometimes it's a constituent issue. I know that, especially on scope of practice issues, that one of the problems we run into is that some of these rural legislators, you know, they may not have an anesthesiologist in their district, but they've got a CRNA that they're very friendly with. And so that creates a natural tension there. But those are tough issues for sure. And at some point, you know, there is a point at which you kind of can't make any more headway. And it might be time to look for someone to take over the reins there. Maybe do it yourself. You know, that might be a great opportunity for you to give me a call, and we'll talk about running as a physician legislator and get some better representation there.
Hey, Marion and Tom, there's one thing that we didn't touch on, the importance of mentoring. I know Tom had a mentor, Dr. Zerwas. I had a mentor. I know Marion's had mentors. If you are feeling insecure, or even if you know you want to do well at this, talk to someone who's been in the field a bit and look for a mentor, because that can that kind of feedback, that kind of encouragement is priceless. And I learned a lot from my mentor, and you can learn a lot too.
And I will also say that, like, if there's anyone out there that feels like they need the personal pep talk, I'm sure there's some way you can find me. I'll be happy. I'll be happy to cheer you on. And I tell people all the time, I really am like a soccer mom who just got sick of the system and decided, okay, I think I can do something about this. And I think there's people that have done way more, but if I can do it, you can do it. We did have another question that came through. Brennan, we're still okay to surge forward? Yes? Okay, I'm going to assume so. The question was, how do you think state and national medical organizations perceive grassroots physician groups, especially the new groups emerging because of leadership voids at the state and national level? I'm fresh from our Pennsylvania House of Delegates from this past weekend, and I was particularly pleased that we got a resolution passed by which now our state medical society is going to have to tell its membership when the lawsuit updates need to be made about the mock lawsuit that PPA helped crowdsource fund. So it's a big effort on PPA's part to enact meaningful change in maintenance of certification. And now we have the state medical society behind us. Do I think that everyone within the organization and the leadership loved it, that grassroots was discussed? No, but various leaders in the organization actually brought it up. Yeah. Oh, we okay? And I'll continue then. And served as kind of like a wingman. They brought up the work that PPA and its other membership organizations of Free2Care have been able to do with the grassroots group. And two people that had been former presidents of the State Medical Association mentioned our grassroots efforts by name and wanted the leadership of the medical society to be aligned and to start looking towards grassroots as a way to collaborate and to get things done. So I think that it's varied within an organization. I think there's some feeling of threat from the grassroots, but those of us who were there that are grassroots advocates as well, held our ground. We were respectful in the way that we addressed everyone. We gave people the kudos and the credit when they needed them and deserved them, and really put out our effort to be collaborative. So.
All right, Marion. Well, we have the next panelist. So thank everybody for joining.
Wonderful. Thanks for having us go
Thank you.
over. And Bob and Tom, thank you so much for your fantastic leadership.
Thank you all. All right. I'm just going to move everybody off. All right. Well, we have Dr. Craig Wax and Dr. Wesby Fisher with us here. Gentlemen, welcome.
I'm there. Thanks.
Thank you so much.
I'm glad y'all can make it. Doctor's life is always a busy one.
Sorry, guys. Had to do a little work for a living.
Well, I appreciate you taking out the time today. And the topic of this one is maintenance of certification. And I took a deep dive into this earlier, and this is a mess. So, yeah, you got a lot of work cut out for you on this one. And it seems like to me that this is a very important thing, that there's a lot of unneeded regulation and a lot of hoops to jump through that I think just doesn't need to be there. And I think that's what the campaign is about and the lawsuit. So, without me trying to get into it, Dr. Fisher, if you would mind just to give an overview of what it is and what we're trying to accomplish with this particular lawsuit, and just kind of take it from here.
Well, thank you so much, Brennan. A couple things for folks to understand. This is not just one lawsuit. This is a whole series of lawsuits that have been filed against the American Board of Medical Specialties and their member boards. Really, the first one started back in 2004 by the American Association of American Physicians and Surgeons. There was an antitrust lawsuit that was filed there that's been weaving its way through the courts. And that suit is still pending. We don't have final resolution of it either. Perhaps the largest cluster began in December of last year when the American Board of Internal Medicine was sued for a claim of antitrust violations due to illegal tying behavior of tying this maintenance of certification to initial certification, which we all had to pass at least one time, basically to show the adequacy of our residency training. And then in 1990, mysteriously, the American Board of Internal Medicine decided to have repeated testing, claiming that doctors needed to keep up, that we had to, medical knowledge was changing all the time. And that was despite the fact that we already had to do continuing medical education for keeping our state licenses at each state in the United States. So maintenance of certification mandate became required for all physicians that wanted to remain board certified, because they switched it from a lifetime certification to time-limited certification. And initially it expired every 10 years. And as time has gone along, we now have to make payments every 5 years to acquire so many mock points that they want us to do. Those mock points used to be 100 points over 10 years. Now it's 200 points every 10 years, which means twice as many payments for continuing education that the American Board of Internal Medicine says that we have to do. And as opposed to the continuing education that we ourselves believe we need to do. And the remarkable thing is that, physicians have always believed that they're capable of making life and death decisions every day. But when it comes to picking our own CME, according to the American Board of Internal Medicine, we're incapable of doing that. And therefore, we must follow what CME they want us to do. So it's a very strange mandate indeed. And unfortunately, because they no longer recognize their board certification as valid if you don't pay them on a repeated basis, they now basically what's happened is they've worked with the hospitals and insurance companies that we can lose our hospital privileges or insurance payments if we don't keep up with these payments to the American Board of Medical Specialties member boards. So because of that theoretic illegal tying, and antitrust violations. The American Board of Internal Medicine in December was sued by 4 physicians, all internists, 2 of them gastroenterologists. Another was a general internist in Detroit. And these people all had harms imposed by them. And I'm sorry, the last one was an infectious disease specialist, but they all had lost their privileges or were unable to receive insurance payments or couldn't get a job, lost income because of the restrictions required by payment for maintenance of certification. And that's the grounds of the probably the biggest part of all these lawsuits that have been filed against the ABMS member boards. In addition to the antitrust violation, there's a monopoly charge claim that was filed against them. Also a racketeering claim against the American Board of Internal Medicine. And because of the exorbitant salaries, the lavish extra perks that these board members have thrown on themselves, unjust enrichment was also added to the claims, which are state required things. These are supposed to be nonprofits and not a place to be making large sums of money. And I think it's important people understand that this is much more than physician testing that is being sold. Basically, when we register all our data for these tests, you can't read a text and get credit for reading the text that they send you and taking the test. You have to be on a computer in order to acquire your mock points. And that's because they're measuring everything you do on that computer and selling that data to third parties. So it's also about our privacy as physicians, not to mention basically a heavy-handed way to make sure that they are guaranteed their payments on a regular basis because they tie it to our employment or insurance payments. Only the ABIM, which is the largest member board of all the 24 member boards, the American Board of Medical Specialties, has the racketeering charge currently. But the American Board of Radiology was sued, and as was the American Board of Psychiatry and Neurology. The board member of the American Board of Psychiatry and Neurology made over $2 million in a single year. So we have to worry about what these people are doing this for. And it certainly seems like it's much more than to assure physician testing. These people are making large sums of money for themselves. But probably the biggest problem with the maintenance of certification mandate is it can affect the physician's right to work. So despite us working and getting the continuous payments and all of that, the real problem is that we can actually lose our job unless we pay this money, and that's where the antitrust claims sit. And there have now been additional suits filed against the American Board of Emergency Medicine and the American Board of Anesthesia. And I think Craig has information also regarding the American Osteopathic Association. He was involved and actually was a plaintiff in the lawsuit against them. So Craig, do you want to fill us in on what happened there?
Oh, thanks very much. Again, I appreciate Citizen Health hosting this conference, and certainly the ability to work with you, Dr. West, with regard to the mock issues, you being an MD, me being a DO. And that means that there were different mechanisms for certification primarily, although there was some crossover. You had mentioned ABMS, and on the DO side, there was the Osteopathic Graduate Medical Education System. And as of next year, they're coming crashing together. That it seems from downward pressure from the government with regard to residencies, that MDs didn't have enough residencies to suit their schools, and the osteopathic profession had more residencies and students than to suit the amount of physicians that could possibly be put through. So what happened was both organizations are coming crashing together with ACGME as of next year, which I think is an issue. If the MDs don't have enough residencies for their students and DOs don't have enough residencies for their students, then how we're putting them together in one system with one central power core going to address that need? It doesn't make any sense to me. At any rate, you've done a lot of great work, Dr. West. Thank you for that. Also building on the original AAPS lawsuit that unfortunately languished for years in the same area, Chicago, Illinois, again for restriction of trade. Because as you so well point out, that a physician that finishes residency, even when you complete residency, if you're not board certified and recertified every 7 to 10 years, or at the whim of the boards, that you can't get a job, you can't participate in a government program like Medicare or Medicaid, hospitals won't hire you, and being in private practice, there's no real successful way to function with any of the current payment mechanisms. And that's certainly a big issue. So we took that issue on in 2017. 4 DOs from the New Jersey area sued the AOA. And as you had talked about illegally tying, that was a good segue to this with regard to the AOA. In addition to saying as of 1997 that we all had to be recertified, and that program has taken more time and more money as they come up with more things for us to do, despite the fact that we all do yearly CME at our discretion and per their criteria. So in addition, our data has to be reviewed by outsiders, and that costs money. It costs to take the periodic testing that it could be a one winner take all test for thousands of dollars in a place that's not near to you, or it could be online as they're trying to do it now to make it more humane, but it's still not necessary. So 4 of us plaintiffs sued on behalf of the entire class of all those certified on the DO side. And after 2 years, we had reached a settlement with the AOA. So what they had done, in addition to what the ACGME side had done, or ABIM, I should say, had done, they also tied our repeated board certification to membership in the AOA, which was approximately $750 a year. And what relationship did that have to our education and board certification? None. But it was a source of revenue for them, in my opinion. And if you've got something good, of course, we would pay, we would come, you would support us, and life would be a dream, sweetheart, with regard to physician governance organizations. However, when you don't support us, you're not listening, and you're just forcing us to pay, well, that violates not only federal law, but also New Jersey state law with regard to anti-racketeering. So we brought this to a close in the past year, that starting in the current following year, that their dues would be reduced by $90 for those who wish to continue, but immediately the tie is broken that in order to maintain your board certification, you don't have to continue to be a dues paying member of the AOA for the previous 3 years, because that broke state and federal law. So that was taken. So fortunately, we were able to draw, I guess, what they call in the legal profession first blood with regard to these sort of edicts coming from the top that violate both state and federal laws and our right to practice autonomously. In addition, the AOA will offer CME as part of their program. If somebody wishes to be a member, they will contribute $2 million to an osteopathic awareness campaign, the likes of which I've never seen so far in the year that this is supposed to be available. Also, CME can be online as opposed to being in person at their conferences, which they sponsor and make money off of. Also, there's supposed to be a committee of private physicians to be advising the AOA board, and I have not have any information about that, whether or not they've established that. I certainly have not been asked to be a member, although I would certainly consider membership in the AOA to actually have a voice, certainly. And the other thing is that people certified prior to 1997 were guaranteed lifelong certification, and then all of a sudden they took that away. And I know on the MD side of things, they've successfully taken that away, and that's part of what your lawsuit, I'm sure, alleges. Having said that, on the AOA DO side, that they are guaranteed lifelong board certification. They can say they're not continuing with their program, but they will not have their board certification removed or forcefully taken from them, endangering their job and their ability to practice osteopathic medicine in whatever capacity they choose or practice. So we're actually interested now, because we haven't really seen any resulting anything from the AOA. In fact, a lot of DOs out there don't even know that this case has gone through. I mean, the AOA had, whenever there's a settlement or a judgment, they have to make everyone in the case aware, and that includes all of the class of all DOs and MDs that might be certified by them if that were the case, to be notified of this and to have all of these settlement terms available to them. And to this date, I do not have evidence of either. So if anyone out there that's DO board certified has any evidence that they are or are not abiding by these things, please let us know. You can go to the letters IP, the number 4, the letters PI. So ip4pi.wordpress.com. Go to that blog, and in the search bar, type in AOA settlement, and you'll find the settlement terms. And if you would kindly feed back to us as to whether or not they're abiding by those terms, it would be very, very helpful, because I remember the judge in the Camden courtroom in the federal courtroom in Camden, New Jersey, said that because I was skeptical as to whether or not, despite having a verdict, not a verdict, but a settlement, that they would comply with these things, although they did theoretically. And the judge told me that he would want to know in straight up fashion whether or not, because he would not take kindly to someone not going along with his settlement. So that's where the AOA part stands. It'll be interesting to see what happens as of next year, as the AOA graduate medical education programs will be absorbed by the ACGME. In fact, the president of ACGME next year is going to be a DO. So it will be interesting to see how all of that works. And finally, as I was saying, it'd be important for us to hear anything from any DOs or those certified by DO groups out there as to what's going on. The last thing that I was going to say, and Dr. West has talked about this top-down management for dollars, as it were, to manage others at our peril and cost, certainly, and with no data to show any justification or any positives to come out of it. On the DO side, the American Osteopathic Association owns all its member boards. A few decades ago, they took them all in-house. So to me, it's beyond collusion potentially, to the point of monopoly, basically, because there are multiple boards, but all owned and governed in the same way by the same organization. Thank you.
Thanks, Craig. I think your point's well taken. We have to understand the American Board of Internal Medicine came from the American College of Physicians and the American Medical Association. They were basically derived from that organization, and they've worked collectively to begin to make sure that everybody followed in line based on their own specialty, certain criteria set forth by the American Board of Medical Specialties. The American Board of Medical Specialties also owns the Maintenance of Certification trademark. And I think it's important to make sure that people understand kind of where all these lawsuits stand at the present time. So I'd like to quickly run down that. Perhaps the largest blow recently was a judgment made by senior judge in the Philadelphia court system against the American Board of Internal Medicine that initially dismissed the tying claim and the unjust enrichment claim against the American Board of Internal Medicine with prejudice, meaning that the plaintiffs could not go back and sue on those grounds. However, did allow 14 days for the plaintiffs to amend their complaint under the monopolization and racketeering charges that were filed. In other words, there was probably enough that he did not feel comfortable dismissing those two charges completely with prejudice. And but they only gave him 14 days. And it's unusual for a judge to give plaintiffs such a short period of time. Usually it's a month to amend your complaint before they dismiss or write a final summary judgment on the case. In reviewing those claims, there was some concern about the judgment that came down from the plaintiffs. Obviously, they were disappointed to learn this. Because I think most of us who have been through this process, and people here should understand that I am a grandfathered internist, but I am not grandfathered for cardiology or cardiac electrophysiology. So I straddle the fence. I've been practicing medicine and understand the changes that have occurred throughout this cycle of going from lifetime certification to time-limited certification. And for that reason, I think the entire concept was lost on the senior judge. I don't think he really understood. And there were some procedural issues that the plaintiffs took issue with. So they decided not to amend their complaint. They didn't think it was reasonable to do so in 14 days. And instead, once the final summary judgment is filed, to the best of my knowledge, they are planning to amend or to appeal the full complaint at the appellate level. So I think we have to wait and see what happens once the final judgment comes as to how the legal wheels will turn. But it's clear that no one thought this was going to be an easy battle. The American Board of Medical Specialties and all of their collaborating entities, which includes the American Hospital Association, the American Medical Association, all of whom make up the ACGME, including the ABMS. They'll stop at nothing, basically, we think, to continue this process for physicians. So we'd like very much for things to go to the appellate court. It's amazing that physicians have not gotten their day in court, despite very sound filing that went forth. But nonetheless, we have to abide by the rule of law as it currently stands. So I think it's important people understand what the plan will be, as to the best of my knowledge, regarding the American Board of Internal Medicine. The American Board of Radiology and the suits against the American Board of Psychiatry and Neurology, the suit against the American Board of Emergency Medicine and the American Board of Anesthesia, as well as the American Board of Medical Specialties. Those suits are all fully briefed, but no ruling has come down on them yet. The hope is that by the end of the year, we'll start to get some of these suits coming in over time to learning when and if any of those suits get to go to court and go to discovery. I think that the board members will be very interested in not allowing this case to go to discovery. And that will be up to the plaintiffs themselves to decide if they want to continue or settle. We can only hope that they'll want to go on and to court in order to get all of the issues brought out. But if any one of these suits wins, it will help the other suits that are filed in court. They are very synergistic suits, and they form a precedent going forward. So you can be assured that the American Board of Medical Specialties is using the ABIM ruling as a precedent for other cases that are already filed against it. but there have been counterpoints made on both sides. So not being a lawyer, I have to leave it to the legal team to who's working on these. And I think there's quite a few legal teams since these lawsuits are filed nationwide, working on this very issue. But clearly there must be grounds for a belief that these are really cases. Otherwise, we wouldn't have this flurry of lawsuits being filed. The Practicing Physicians of America, which is an organization that I helped co-found, and Craig is one of our board members, as is Marion Mass, who's been on earlier. You know, and we've got Judith Thompson, Naran Al-Agba, and Brian Dixon all on our board, and all of us got together. We are very disparate people. I'm a subspecialty physician, cardiac electrophysiologist. We have two pediatricians, Naran and Marion. We have a DO, Craig, and we have a family practice physician with Brian. And Judith, our president and CEO, is our kind of master of ceremonies, mother superior breast surgeon. So using those folks, all of us firmly believe that physicians should be allowed to have autonomy. It's in our patient's best safety, in our patient's best interest for safety and quality of care. We need to have the ability to learn what we feel we need. These boards have no idea our scope of practice, what our practice situation is like. They have a one-size-fits-all metric that they're thinking that a computer and staring into a computer screen and answering a question or two based on the latest literature is going to make us better doctors. I mean, it's ludicrous. So unfortunately, we have the entire academic medical community siding with the American Board of Medical Specialties. When there, as Craig mentioned, absolutely no proof that recurrent maintenance of certification does anything beyond what continuing medical education does and has already done for us throughout the years. And I think that this is going to be an important fight for us. I think it's critical that doctors step up. It's just amazing to me that we haven't even had every doctor contribute $10 to our GoFundMe campaign, which we'll put up later with a link to support this effort. When everybody, I mean, we've done polls. I got over 7,000 physicians, and 80% of them said they hated maintenance of certification. And they thought it was one of the leading causes of burnout for them and their family, the time they'd have to pull away. I mean, we have to stop what we're doing in the middle of patient care because we're about to lose our privileges. We have to go buy this $1,600 packet of information. We have to cram it. It's like the Encyclopedia Britannica. And then take time away from our family and our lives, not to mention our patients, where we have to go off to a testing center or do some other testing, or do it every 2 years, or every 5 years, every year. I mean, it gets ridiculous just because these guys want to maintain their cash flow. And I think that it's disruptive to patient care. It's distracting from patient care. It's not proven to improve patient care. And the worst part of all of this is the very undisclosed things that have happened with our data and with our personnel, in our personal lives when we do these tests. It's all being sold for large sums of money. And I think, we have to have people who push back against this somehow. Otherwise, we're going to basically have ourselves relinquished to mid-levels. Not that those people aren't helpful, but they don't have to do this maintenance of certification stuff. And we're seeing a lot of doctors leave the practice of medicine, become suicidal, very disenchanted as they're overawed or overwrought with the work that we have to do just to satisfy these bureaucratic, unproven needs. So please, folks, if you can step up that are listening in, get your friends. We don't necessarily need everyone here. If every person would turn to 10 people and have them contribute a few bucks to the GoFundMe, we should be able to get over we're only asking $400,000. These lawsuits probably the ABIM lawsuit alone with legal fees is probably going to approach $10 million. We're not asking doctors to contribute that much. And I think that if we, can work on trying to get this initial money, it helps us get experts. It helps us get legal opinions in support of the plaintiffs that are working very hard and exposing themselves for this effort. So this is going to be a big piece of what we as doctors and fellow colleagues can do to help end maintenance of certification nationwide. Any other things? I noticed one of the other things that came up, I think it's worthwhile to mention that a lot has been done outside of legal means to try and prevent this monopolization of our board certifications. So we've tried to go to the AMA and have put through resolutions there without success. The National Board of Physicians and Surgeons is an alternate board created by Paul Tierstein and many of his colleagues. Paul Matthew comes to mind from Mass General and the Brigham. Those guys have worked tirelessly to create an alternate board that costs a fraction of what the American Board of Medical Specialties maintenance of certification product. They basically verify continuing medical education credits and give you a certificate saying you've participated in continuing medical education credits. It's like $85 a year, something like that. It's not very expensive. Obviously, if physicians were to migrate there and force more and more hospitals at their own place to accept the National Board of Physicians and Surgeons, that would also put pressure on the American Board of Medical Specialties and divide up their monopoly over the maintenance of certification program. But as it stands right now, unfortunately, too few hospitals are allowing this alternate board to be used for accreditation purposes or for physicians on their staff. And a lot of that is because maintenance of certification and training programs require ABMS board certified physicians as program directors. And the National Committee on Quality Assurance, headed by Margaret O'Kane, Margaret O'Kane, they certify which insurance companies can receive monies from the from CMS under the new Affordable Care Act. And then wouldn't you know that the board member of the National Committee of Quality Assurance happens to sit on the board of the American Board of Medical Specialties. So there is a collusion there, and it's not surprising that insurance companies, as a result of that, require ABMS board certified physicians in order for people to receive payments from those insurers. And Blue Cross Blue Shield and Aetna are two of the biggest ones that I'm aware of that have that tie. So this is also part of what's going on with the ABIM lawsuit. Hopefully, if we can move that into the courts, we'll be able to expose this collaboration with the insurance companies, because I think that's a big piece of why hospitals use it as their excuse. Well, if we can't get insurance payments, we're going to have to not take the National Board of Physicians and Surgeons. So I think it's important that people understand that particular collaboration exists. So I think, we have to appreciate that this is all part of the way to control physicians. In the United States, we have the magic pen that writes orders. We have to refer people and have the ability to send people to other places. It is in hospitals' best interest to have power over their employees and to keep the physicians under one roof and to refer internally. They are able to increase their profits as well. So the hospitals aren't totally innocent in this whole process either. And the insurance companies are part of it. Pharma's probably playing a role because they can't get into doctors' offices in many of these places, and many of the teachings that go on in the ABMS world that are forced on physicians are in part funded by industry. So to make sure that they can get their particular product in front of a physician. So all of these things are areas that we need to, appreciate. This is not going to be a simple battle. It's going to go on for a while, but right now it looks like hopefully by the end of 2020, we'll start getting some resolution to some of these things.
Thanks, Dr. West. If I could jump in for a second.
Sure.
Thank you. Excellent work as always. It's a pleasure and privilege to work with somebody who's as driven, methodical, and passionate about doing the right thing as you are, especially since you're partially grandfathered, which is interesting. Very interesting conundrum. So you can see both sides, and I commend you and appreciate working with you on this. So take-home messages from this, just to summarize, as I have to run and perform some procedures, not catheterizations, but other procedures. One is the National Board of Physicians and Surgeons at nbpas.org. They are also the National Board of Osteopathic Physicians and Surgeons. They will certify MDs and DOs by their yearly participation in CME, period, as it should be. None of us physicians says that we shouldn't do yearly or ongoing sorts of self-education, and the NBPAS and NBOPAS recognizes that and wants to make that the standard and give the other certifying boards a run for their money, and more programs are recognizing them. The other thing that Dr. West mentioned was Practicing Physicians of America, which I have the pleasure of sitting on the board with other wonderful people like Dr. West, Dr. Marion, and Dr. Judy, Dr. Brian, and all the adjuncts that help us with this ongoing issue. If you can, join PPA. It's no cost to get registered with us, and it's at practicingphysician.org. It's hugely important. Not only will you have all the information that we're talking about, you'll be able to interact with us and be able to help us to move forward on all of our own issues that we all need to move on, to be able to make physicians independent again and help us to serve our patients in the way that we need to do it, that is time-honored, respected, and in a non-profiteering fashion, let's say. And lastly, with the AOA lawsuit settlement, if you could go to ip4pi.wordpress.com, you'll also find lots of mock things in addition to Dr. West's blog, which is very, very good regular read. Where he finds time for all these things, I don't know, but we all have to find time to fight the good fights as we've done now for several years. But I need to find out to let our legal representation know whether or not the AOA has kept up their part of the settlement bargain. I have no evidence that they have, and I need to find out either way. So if you could get back to us with details, the best way to do that is through Practicing Physicians of America, which is on Twitter at PPA_USA, where there'll be links to a lot of the things we've spoken about. Plus, we're at Practicing Physician, singular, that is practicingphysician.org. Thank you. And again, allow me to run. Be well.
Thank you, Dr. Wax. Appreciate it. All right. Well, we have, I think, Dr. West, I think you've been answering these questions.
I've been trying.
Yeah. All right. All right. Well, there's one thing that I want to bring up here, and it is the GoFundMe campaign. I'm impressed by this, and I just like the concept of having a lot of people come together for one cause and contributing a little bit, whether it's time or effort, or in this case, dollars, to the effort. And it raised close to $400,000. And if you look at GoFundMe, about a third of all the money raised is for medical cases, whatever that may be. I'm not sure if this actually falls under that, but I'm curious to know, there's about 1,600 people that have donated. That's a very small percentage of all the physicians out there. If you do look at, just say 10% of all physicians right now, around about 100,000, if everybody that donates up $100, that's pretty much all we need for what you said, $10 million. A little bit more than that, there could be a lot of change happening. There's a lot of power behind capital, coordinated capital. So I'm kind of getting to what else can we help with as far as crowdfunding? Do you see any other thing that we can kind of tap the power of the crowd and organize around?
Great question. I've been doing this now almost, I don't know, 16, 18 months, something like that, a year and a half. And it's actually quite disappointing that the only amount of money we can raise is about not even $400,000. And that's really all we're asking. And why is that? I think it's important to understand that half the people that have donated, just about half, are doing so anonymously. People are really threatened by the American Board of Medical Specialties. They're threatened that they might lose their job. They're threatened that if they speak up against the quote machine that, they're vulnerable and they don't want to lose their income for their families. They don't want to jeopardize their employment. And I get that. I think that's a big piece of what's going on. I can also say that I think we are in an echo chamber on social media. I think that what we don't have and what we need are large email lists. We need a lot of people out there spreading the word. And I think we have to use good old garden variety snail mail to do so. I think that would help. I also think, it's interesting. I'm in a group of over 40 physicians and probably only about 5 to 10 maybe have donated. A couple of them are grandfathers, which is heartening to me because they know that this is really a scam. And they want us to fight the good fight. But it's surprising to me, these younger physicians, a lot of people don't, first of all, they go, well, it's, look, it's only $2,000 every so often, no big deal. But we have to understand that those prices have gone up 352% since the year 2000. And they're only going to grow, particularly with all this legal activity going on. And I think that that's way above inflation, and the time away from family means something. The loss of autonomy and feeling extorted that you have to make this payment to keep your job just isn't right. And we need to push back against it. It is amazing to me that we have people that have positioned themselves with such authority for political purposes, really. And I think this is a big push toward the single payer model, if for lack, and I think it's going to actually be the capitalist model in America. I think, I don't want to get into whether single payer is a good thing or a bad thing, but I think we've had a very large push to trying to have a lot of different things done in healthcare that the insurance companies realize that this is a bubble and they need to get rid of the risk that they have to assume. And more of our payments are being borne by our citizens. And I think that there's a reason for that. They are trying to get rid of the risk to the insurance companies and give it to others. There's such obfuscation of pricing. We have no idea what things cost. And unfortunately, physicians and our data are critical for all of these algorithms that are being developed for artificial intelligence. And MOC is a way to keep that database up to date as to who's actually practicing, what they're doing, how many procedures they do, et cetera, your social security number is being sold. All that information is being used for other people to covertly ration care so that they can make huge profit. And it's a very complicated, tortuous thing to understand how MOC fits into that. But that's why we need these lawsuits, because they will help put sunshine on the pricing issue and how this data is being used for the benefit of the large bureaucratic machine that is the insurance companies and hospitals that are working behind the scenes to keep their profits high and the business of medicine lucrative for them. So unfortunately, this is happening at our patients' expense. We unfortunately are left no choice but to pay into this system that is perpetuating this problem for our patients. And I think it's almost paramount on all of us to do what we can to help our patients push back against these problems. And I think mock is a way for us to begin to understand how our data are being used.
Yeah, that's something that I think is being discussed now, because in the past it has not. People have not thought about their data, but with Cambridge Analytica and a lot of the consumer data stuff coming out, people are starting to say, well, yeah, our healthcare data is being used in the same way. And I was reading an article about when you get a prescription filled, before you leave CVS, your data is already sold. It's that quick, like before you can get out of the parking lot. And you were being taken advantage of with our data, or our data is being used to profit and we're not getting a dime from it. That's another conversation there. But we're looking at this mock lawsuit for the physicians coming together to basically get rid of this. Is there a group that entirely focuses on lawsuits, fighting these types of mandates and regulations? Really just I guess a law firm that's sole purpose to do something like this?
To the best of my knowledge, there's no single law firm that's doing this, but certainly there are law firms who specialize in antitrust and business antitrust law, that kind of thing. There are a number, obviously, of lawsuits or law firms that are involved in these lawsuits that are underway. It is very hard in the city of Chicago to find a law firm that isn't affiliated with the American Medical Association, because they use everybody in Chicago, all the big law firms. So it is amazing that there's one law firm from Chicago who's kind of taken on the machine here with at least 3 of these suits to date. But there's also a law firm in California, and California may be a more favorable environment for these antitrust suits. There was recently, beginning of October, just earlier last month, the lawsuit of an internal medicine physician, a Puerto Rican internal medicine physician who was falsely accused of cheating on his ABIM exam. His countersuit was just filed in Puerto Rico. And you can bet that they're going to push back hard against that. But there is all the principals of the American Board of Internal Medicine who helped begin this maintenance of certification are named in that lawsuit. And it'll be interesting to see if they all get free funded flights by diplomats of the ABIM to Puerto Rico in the middle of the winter to undergo that, to get their depositions filed down there. Certainly they'll probably use it as a vacation spot, just like they took away $6.5 million of our dollars to the Cayman Islands. So, unfortunately, I don't know how the ABIM is going to withstand all these lawsuits and the cost of what they must be costing them millions and millions of dollars. But I think we have to realize that these things are going to be a challenge going forward. And with that, I've got my dog going crazy in the background.
Well, we'll go ahead and it's about the hour mark, so we can wrap it up here.
Okay.
If you have any closing remarks, go ahead. But if not, you can just close it up and move on till the next day, till tomorrow. Anything to add? Any other last minute questions? I think we've got. Yeah, I think everybody else is
heading out. Thank you all for your time. I appreciate it. And thanks, Brennan, for moderating this. It was great.
Thank you, Wes. All right, well, everyone, tomorrow starting at 8 a.m. Eastern time, we will resume. I have 4 hours of that. I look forward to seeing you tomorrow.
All right. Thanks again.